अंजनी, अंजनी, अंजनी,
हाँ जी।
प्लेटफॉर्म का क्या स्टेटस है?
प्लेटफॉर्म 3 मिनट पहले लाइव करवा दूंगा।
ओके। एक और चीज है, यूट्यूब का लिंक भेजा।
यूट्यूब पर लिंक भेजा था, वापसी
क्या कह रहे हो?
आप कहाँ बैठे हो? आपके उधर से मेरे को डबल आवाज आ रही है।
रुक जा, बाहर जाता हूँ। ठीक है, अभी ठीक है।
हाँ, हेलो।
मैं ये बोल रहा था, बंद कर दो।
हॉल का साउंड बंद कर दो ना अभी 2 मिनट।
यूट्यूब का क्या स्टेटस है?
यूट्यूब का आप ग्रुप में
मेरी
डाला था
आवाज
कुछ
बहुत
दिन
धीरे
ने।
आ रही है। हमारी आवाज बहुत धीरे आ रही है मुझे।
क्या आ रही है? हेलो।
हाँ बोलो अंजनी।
मैं कह रहा हूँ फीड चेक कर लो यूट्यूब पे एक बार। मैडम को बोलो फीड चेक कर लेंगे।
ओके ठीक है।
लैपटॉप आ रहा होगा तो शायद।
मेरे को नहीं आ रही आवाज, मैं देखता हूँ।
मेरे इंट्रोडक्शन में डॉक्टर विवेक की प्रेजेंटेशन आएगी, बाद में बताएंगे। मैं इंट्रोड्यूस करूंगा उसके बाद।
तो यहाँ से सुशील, एक तो इसमें आवाज नहीं आ रही मेरे को। आई एम नॉट गेटिंग एनीथिंग। ये पहली प्रेजेंटेशन सर की है, इसको हटा यार, ये काम ही नहीं कर रहा। कल तक कर रहा था, आज नहीं कर रहा। समझ गए? एक मिनट, प्रोग्राम की कॉपी कहाँ गई? प्रिंट आउट निकालो ना। अरे सर मैंने 5 प्रिंट आउट कॉपी बोली है। नहीं है सर, वो अपडेटेड होगी। प्रिंट आउट नहीं है सर, ये प्रिंट आउट प्रोग्राम है। ये ले, उसके पास रखा हुआ है, तू कह रहा नहीं है। ये उसके पास रखा हुआ है, वो नहीं देगी वो। भाई मैं दे रहा हूँ, मुझे लग रहा है आप अपनी वीडियो ऑन करो, मैं दिखा देता हूँ। हाँ हाँ
Check one, check one, one. आ रही सर? रुपेश देखिए ऑडियो नहीं आ रहा, हेडफोन ठीक है, मैंने चेक कर लिया। चेक 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 आ रही है। और हेडफोन देखो उनको क्यों नहीं चल रहा उससे लैपटॉप में, पोर्ट में दिक्कत तो नहीं है इसके? चेक 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 वन चेक 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 आ रही है। चेक 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 ठीक है सर।
अंजनी 30 सेकंड्स में रोल करेंगे। हाँ
ओके
फोकस।
Hi. Yes. Thank you.
अंजनी स्टार्ट।
स्टार्ट
अंजनी स्टार्ट करो।
स्टार्ट कीजिए।
Good afternoon, everybody. For more than last 1.5 years, we all know that we are going through the global pandemic of COVID-19, but we still all have been working continuously with a common aim to learn, innovate, share, improve, and eventually to save more lives. Distinguished faculty, delegates, colleagues, dear friends, and ladies and gentlemen, on behalf of the organizing committee at Advanced Institute of Liver and Biliary Sciences, it's a great honor and pleasure for me to welcome you all to the second AILBS International Conference in association with the Liver Transplant Society of India midterm meeting. The theme for this year is Emerging Frontiers in Liver Transplantation. Currently, we are in the exciting era of liver medicine, surgery, anesthesia, and critical care that have enabled us and the world to see great advances in the last decade. This conference has been designed on the same lines to provide an innovative and comprehensive overview of the latest developments in the liver transplantation field, primarily in areas of living donor liver transplants, including minimal invasive donor hepatectomy, laparoscopic, robotic, transplant oncology, including management of advanced SCC, new indications including cholangiocarcinoma and colorectal liver metastasis, transplant immunology, including avian-compatible liver transplantation, and various other liver diseases, including acute or chronic liver failure and the upcoming pandemic of NASH cirrhosis, pediatric liver transplants and their long-term management, and most importantly, transplant research, including basic science, collaboration, and other history. I'm proud to say that many distinguished international and national transplant HPB surgeons, hepatologists, anesthetists, intensivists have joined us as a faculty. We have been joined by more than 150 faculty, including 51 international faculty from 26 countries and more than 100 national faculty, delivering 65 talks in form of lectures, panel discussion, debates, workshops, and surgical videos over a packed and interesting program for the next 3 days. I'm pleased to tell that more than 250 delegates have registered over the country, and also have been registered by the participants from countries where liver transplant services are not available. I'm sure that you will have a stimulating and interesting conference. In this meeting, you will also have a chance to, especially for the trainees, to point out and influence future work in field of liver transplantation. At the end, I'm confident to say that we will be meeting in real world soon. Thank you. Now, I would like to invite Dr. Vivek Vij, Chairman and Chief Surgeon at Advanced Institute of Liver Biliary Sciences, Fortis Hospital, India. I also would like to invite Dr. Ritu Garg, who is the Zonal Director at Fortis Memorial Research Institute, Gurgaon. Can I ask Dr. Ritu Garg to come on the dais and say a few words?
Thank you, Dr. Singhal. Thank you very much for giving this opportunity. It's an absolute pleasure to be here. And I welcome all the faculty and delegates around the world. It's indeed a very, very interesting phenomena to see that all of you, such eminent people in your respective fields and respective countries, have come together to deliberate and discuss and learn over next 3 days. I think last year has been quite challenging for everyone, most of all for all of you frontline workers. Not all of you as senior health professionals have challenged the frontiers of science and also overcome the COVID pandemic, but continue to save lives. That is very, very inspiring for everyone across the world. And I think the testament about saving babies with severe liver diseases, as well as continuing to excel and developing new techniques like laparoscopic donor hepatectomy that we have seen a lot in this hospital over last 1 year, has been absolutely awe-inspiring. Seeing families coming from across the world and fighting through the travel challenges, restrictions, COVID tests, and yet land up here, but go back happy, healthy, with amazing smiles is very heartwarming. And that is what keeps us all motivated and continue to do what we are best at, saving and enriching lives. So thank you very much for joining us. And I wish everyone all the best. I am sure the next 3 days will be about very enriching discussions, and there'll be a lot more to take home at the end. Thank you.
Thank you, Dr. Garg, for those kind words. Now I would like to invite Dr. Vivek Vij, Chairman and Chief Surgeon, AILBS at Fortis Hospital. Dr. Vij has an experience of more than 200 liver transplants over the last decade at Fortis Hospital. He has also been instrumental in setting living donor liver transplant program in various Fortis and non-Fortis hospital across the nation and across the border too, in Mongolia and Nepal. He has been awarded by Ministry of Health and respective government at Mongolia and Nepal for establishing their liver transplant program. He has been instrumental in establishing the laparoscopic liver surgery at Fortis group of hospitals, including the lap donor hepatectomy, despite all the challenges in private sector, especially in these COVID times. Please, Dr. Vivek Vij.
Thank you very much, Ashish, for these kind words. First of all, before starting my talk, I would like to thank, and foremost, my team, who always stood by me in thick and thin times. And we have seen a lot in last 1.5 to 2 years during COVID times. But my team stood by me, and I, from my heart, from the core of my heart, would like to thank them for standing here with us and innovating throughout. Always, a great energy, as well as inspiration. My inspiration comes from my team. Thank you very much again. So without wasting time, I would like to dwell on how we developed a laparoscopic donor surgery program in Fortis hospitals, a small journey, how we did it. I think it will highlight the importance of setting up a new technical program in an already established liver transplant center. So our inspiration was ongoing reluctance among living donors, because most of the living donors, especially in liver, are young donors. They are daughters, they are sisters, they are brothers, and these young donors have a very long life to live in front of them. It's not about just a medical outcome, it's about their quality of life also, which matters. A long-term quality of life for donor drastically improves if we offer them minimally invasive donor surgery. Of course, a lot of reports coming from East and Europe regarding growing literature of laparoscopic donor hepatectomy also inspired us to dwell into uh, such a new technology. So this pyramid I find very interesting. It fits into all learning processes. So there are 4 stages of learning, which I found while preparing this talk. The first stage is unconscious incompetence, which means you deny that it can be done. So I don't even know what I suck at. So that is the first stage. We were in this stage in 2017 when we thought that it is not possible, we should not do it, it is risky, and all those kind of questions creeped our mind. Then we visited few centers, studied the literature, watched videos, and we thought that no, it is doable. And we entered into a second stage of learning and knowledge, that is conscious incompetence. We were consciously aware that it can be done, but we were grossly incompetent to do it. So we have to now progress further to third stage, that is conscious competence, which means we are conscious that it can be done, but now we are competent enough to complete this procedure. And the last stage, which is stage 4, is unconscious competence, which means we are doing surgery now at a spinal level, which means the processes are set, team is already trained, and when we take up the surgery or laparoscopic donor hepatectomy, it is done flawlessly with the help of team and technology. When we started doing this program, of course, there are a lot of requirements, new requirements, because already established open donor hepatectomy program, of course, sets up the ground for all this. But we need more people to be trained in laparoscopic surgery. We need more people to have skills of laparoscopy, and ultimately teamwork, which is the most important thing. If I today alone wants to do laparoscopic donor hepatectomy, I don't think it is possible. You have to train the team around and take into consideration of many factors which are related to team coordination and everything else. Processes, as we go along doing surgeries from unconscious incompetence stage to unconscious competence stage, we make protocols. And after every surgery, we do audit what went wrong, how we should proceed with the next case. And small innovations ultimately would lead us to a stage where we unconsciously operates on the patient, and uh, and donor hepatectomy, laparoscopic donor hepatectomy becomes very equivalent to open donor hepatectomy. Of course, the wings of technology are the most important thing when we talk of advanced surgical procedures. 3D scopes, energy sources like uh, harmonic, HD1000, Thunderbeat, indocyanine green biliary scans, vascular staplers, laparoscopic CUSA, and certain advanced instruments. They make a huge difference in the way we do the surgery. So today we will see a lot of videos in which all these technologies are being used to their optimal strength. So our stepwise progression, as Ashish told, we have completed more than 1,500 liver transplants in Fortis hospitals, and overall our team has experience of more than 2,000 liver transplants. We then dwelled into small laparoscopic liver resections, including high-rated surgery, non-anatomical resections, anatomical laparoscopic segmentectomies, and laparoscopic liver resections in cirrhotics, followed by hybrid approach for laparoscopic liver donor hepatectomy. And now from 2019 onwards, we are regularly doing pure laparoscopic donor hepatectomy, which includes left lateral, left hepatectomies, and majority work being on the right donor hepatectomy. In 2018, when we were in the first stage, that is unconscious incompetence, we went to Korea, Seoul, to see how people have trained themselves or how people do laparoscopic. And I must acknowledge Seoul National University, Professor Lee, for allowing us to enter their operation theater and have a look at how they do the surgery. Of course, later on, we innovated and we made our own steps and own innovations, but the basic knowledge comes by sharing. I think that is the whole purpose of this conference too, so that we can share what we learned and over the time of last 2 to 3 years. So in 2018 to 19, we just did 2 laparoscopic donors when we returned from Korea. After that, we were struggling for equipments, instruments, and everything else. And at that time, our selection criteria were very strict. We faced a lot of hurdles, technical hurdles from patient position to port placement, almost every step. Every step we struggled at how to do it, which ports to use, which instruments to use, how to prevent complications. And we had a lot of fears in our mind. These were all prime time fears, like how we manage a big inferior hepatic vein, how we transect the liver without excessive blood loss, how we divide the duct without damaging the remnant donor duct, how we fire the right hepatic vein. If it misfires, then what will happen? And the graft retrieval along with warm ischemia time. And over and above that, donor outcomes along with the recipient outcomes. I think everybody talks about donor outcome. So today we will be talking about recipient outcomes too. So I would consider this as a procedure of equivalent strength to open donor hepatectomy if the recipient outcomes are also similar statistically as compared to open surgery. Technology, as I told you, laparoscopic CUSA, Thunderbeat, Ethicon, HD1000, then staplers, vascular staplers, 3D flexible head, and ICG technology. So sharing our experience of living donor liver transplants in Fortis hospitals, till now, we have completed around 75 pure laparoscopic donors. In 2019, we did around 14 donors, followed by in 2020, where we did surgeries only in first and last quarter, as we had a self-imposed moratorium for about 6 months in between because of COVID-19. And in 2021, till now, we have done around 19 laparoscopic donors. So the total till now in Fortis Hospital, we have done around 75 pure laparoscopic donors, which majority includes right lobe donor hepatectomy, and about 10% includes left lateral as well as left donor hepatectomies. So just to compare the quartile data, that in the last 2 quarters, we have done more laparoscopic donor hepatectomies than open donor hepatectomies. So when we compared our open versus laparoscopic donor outcomes, we found that although majority of factors were non-significant, but graft retrieval time was more that was significant in favor of open donor hepatectomy. So we innovated on that, and later on we tried to match the warm ischemia time and graft out time in laparoscopic donor hepatectomy. We will see through the videos how we innovated these procedures. Total operative time was initially more than we, as the learning proceeded, the timing came down and we now match the open donor hepatectomy timing with the laparoscopic donor hepatectomy. Ambulation is much faster in laparoscopic donor hepatectomy postoperative, and biliary complications, although we had our share of biliary complications in laparoscopic donor hepatectomy, but they were not very significant as compared to open donor hepatectomy. So hospital stay was also significantly less as compared to open donor hepatectomy. When we compare recipient outcome, they were similar as far as patient survival was concerned. So the learning curve, there has been a lot of literature telling us about learning curve of pure laparoscopic donor hepatectomy. And these learning curves have been defined on various parameters. These parameters might be blood loss, operative time, warm ischemia time, conversions, or vascular and biliary complications. So we also studied these factors for our group of patients, and we realized that with time, all these factors improve. But the basic is there has to be an extensive experience in open donor hepatectomy, without which I think we should not venture into laparoscopic donor hepatectomy. So our data shows that with time, operative time goes down, blood loss goes down. And now we match blood loss as well as operative time with open donor hepatectomies. Warm ischemia time is a very important factor. All over the world, we think that up to 15 to 20 minutes of warm ischemia time is good enough. But we learned that somewhere the recipient outcome suffered, delayed graft function happens if the warm ischemia time is more. So now we have started doing complete cable dissection beforehand, and our warm ischemia time at present is less than 3 minutes for most of our donors, which matches the open donor hepatectomy program. Conversions, as somebody said, conversion is not a failure. It can happen because of bleeding, bile duct division, and many other steps. We can have different reasons for conversion, bleeding being the most common reason for conversion. So in our series, 5.3% of the patients or donors got converted because of various reasons. The most important reason being bleeding from cava and inability to proceed due to difficult biliary anatomy in 2 cases. In initial experience, as I told you, that we had selection criteria, which were BMI less than 26, graft volume of less than 650, standard anatomy, no major IHVs, FLR of more than 35%. But then we learned that the learning becomes very slow if we start selecting the cases very strictly. So from that point onwards, we started accepting all the cases, all the donors without any contraindications or without any exclusion criteria. And from that time onwards, our learning has grown faster as compared to before. Technical modifications and improvisations, we will talk about these as we go through. There are a lot of video sessions throughout today, and we will discuss these innovations as we go along. So I want to say that Delhi technique, we have to reach the same destination as of the donor hepatectomy, although path might be different. So these are some pictures of our pure laparoscopic donors who consented for pure laparoscopic donor hepatectomy, and they are quite happy, and they are really in praises for this kind of procedure. So I would like again to thank my complete team of surgeons, anesthesiologists, hepatologists, and not my coordinators and administration of the Fortis Hospital for giving us wings to fly. And this is it. This was our journey in short regarding pure laparoscopic donor hepatectomy in last two and a half years. With this, I would like to call Ashish on the stage and start our academic discussion, video sessions, and discuss it further. Thank you so much.
Thank you, Dr. Vij, for kickstarting the conference. Now we're going to move to the academic session. The first talk is on laparoscopic liver surgery. We're going to talk about the precision anatomy for laparoscopic liver surgery. Unfortunately, Dr. Wakabayashi is not there going to attend live, but he is kind enough to send his presentation. So now I would like to invite the chairpersons, Dr. Sanjay Goja. Dr. Sanjay Goja is a program director and clinical lead for liver transplant and HPV surgery and robotic liver surgery at Narayana Health City, Bangalore. And I would like to invite Dr. Rajnikant Pacha. Dr. Pacha is a clinical lead and senior consultant, liver transplant and HPV surgery at Gleneagles Global Hospital, Chennai. Over to the chairpersons.
Are you able to listen? Am I audible?
Yes, sir, you are audible.
Yeah. Thank you, Ashish, for the introduction. I think the next topic, as you have already said, is by none other than the master himself, Go Wakabashi. And it's unfortunate he's not live there, but he needs no introduction, and he is the master of the game, and it is great honor to listen to what tips and tricks he has about laparoscopic resections. Thank you. So let's get it started.
Hi, I'm Goa Kabashi. Thank you very much for this kind invitation. Please accept my apology. I cannot be there. I have no conflict of interest. I've been showing this slide because I like it. The liver is an anatomical organ. But the problem is that most anatomical structures are invisible, hidden inside the parenchyma. When I visited the Quino's graves, it clearly shows that hepatic vein runs along the intersectional plane or segmental plane or crossing those planes, but Grisonum pedicule never across those intersectional segmental planes. When you look up the skies beneath the trees, it is just like a Grisonum pedicules. First branch of Grisonum pedicule, second branch of Grisonum pedicule. Those Grisonum pedicles never cross each other, so you can divide intersectional or segmental planes like this. Professor Makuchi first described the limited anatomical resection because he treated small hepatocellular carcinoma, but he found the segmental area cannot be identified because there are no landmarks of the subsegment on the surface of the liver. That's why he started to inject the dye into the portal vein. 1 year later, Takasaki also described another way to perform a small anatomic resection, like cone unit resection. The third order branch of a Grisonum pedicule, usually 2-3 cone units just create one segment. So segment 5, segment 6, those monosegment consists of 2, 3, 4 cone units. Anatomic resection can be defined as a complete removal of the tumor-bearing portal territory, and it can be also applied to the complete removal of third portal venous territories. Many papers have been published to show the benefit of anatomic resection over non-anatomic resection in short-term and long-term hepatocellular carcinoma, and even colorectal liver mets. And the recent important paper came from Seoul National University, Hoson Han's group, remnant liver ischemia deteriorate a long-term survival. I think that this is must be true because inflammation deteriorate immune response and also the long-term survival. When I was a young surgeon, old surgeon told me that if the patient have anastomotic leakage after gastrectomy or colectomy, patient recurs faster. This case was our first case of limited anatomical resection. Hepatocellular carcinoma located centrally, so we have to perform a central bisectionectomy, but remnant liver function is not good. So indocyanine green retention test was over 25%. So when we look up the DICOM data and realize that we can preserve posterior dorsal side of anterior section. So we decided to perform a medial sectionectomy with ventral anterior sectionectomy. This is a resected specimen, large hepatocellular carcinoma, but it looks like an enucleation of a tumor, but this is anatomic resection with nice margin, but limited amount of normal parenchyma. We've been doing this type of surgery for last several years, so we name it as a parenchyma sparing anatomic liver resection. We published 86 consecutive cases last year. Our technique is very much standardized. Preoperative simulation, we measure volume of each segment or each cone unit, and we identified the portal vein which in charge for the tumor bearing area. During the surgery, we tried to find the portal vein in charge for the tumor bearing area. Then we always clamp from the Hilar plate on the clamp those veins, Grisson pedicle from the Hilar plate, Grisson approach. Operation was very much standardized. We routinely use ICG negative staining to see a clear margin of ischemic area and non-ischemic area. We also respect the Lennec capsule to perform Grisson approach from the Hilar plate. During the surgery, we also refer the branching where to clamp, but also we compare the shape of the area to be resected. We uploaded 4 video clips into this link. Even you have no subscription of Annals of Surgery, you can visit their link to see those 4 video clips. In 2015, we used 3D laparoscope to perform a segment 8 monosegmentectomy. We routinely use the Grisson approach for this type of limited anatomical resection. So segment 8 Grisson was taken and clamped. Then we see a demarcation line on the surface of the liver. But as you see, especially for this kind of a cirrhotic patient, it was not so easy to differentiate the way is the demarcation line. Then we always try to visualize a hepatic vein hitting inside the liver parenchyma. Then we found the clip which I placed from the Hilar plate at the bottom of the area to be resected. That is segment 8 monosegment. So this is a real anatomic resection. We always expose the hepatic vein, which locates as a border between section and sector. In 2016, we can also appreciate the IL technology using a 3D cameloscope. We respect the Lennec capsule to see the space between the liver parenchyma and the Grissom and pedicule to perform a Grissom approach from the Hilar plate. Then the Grissom and pedicule goes to a medial section, was now clipped, and also anterior sector was clipped. Then in the sign in green was IV injection. Then we see some kind of a demarcation line. Then we start parenchyma section following that demarcation line, and also again to see a hepatic vein, and those Grissom and pedicule, which I placed a bulk clamp, was now staple divided. Then finally, mid-hepatic vein is also stapled. Then central bisectionectomy is now going to be completed. Finally, in 2018, Stokes developed IL-4K laparoscope, and this was again monosegmentectomy, segment 8. We routinely use Pringle maneuver and also contrast medium ultrasonogram. Then again, segment 8 Grissom was taped from the Hilar plate, and indocyanine green was injected intravenously to see the clear demarcation line between the border between the segment 7 and 8 and 4 and 5. Then this patient was already received indocyanine green because we routinely use ICG test, a retention test, usually in a couple of weeks before the surgery. Then the hepatocellular carcinoma was uptaked, the indocyanine green, but never secreted, so it was shining like green again. So we realized even during parenchymal transection, we see nice clear demarcation line in the parenchyma. So now the Grissom pedicule was stapled, and this is the border between segment 1 and segment 8. Before this ICG technology, I never expected that such kind of a border between segment 8 and segment 1. So now indocyanine green was, segment 8 was completely removed. So this was a recent case for segment 8, 7 colorectal liver mets and segment 1. So segment 1 is going to be removed partially, but segment 7 is located a little bit deeper. So we decided to perform segment 8, 7 monosegmentectomy even for this colorectal liver met. We routinely use a 3D simulation system. The purpose is twofold. Number one, to identify the portal vein which is in charge for this tumor bearing area. And number two, and also identification of the area of the shape to be resected. So IL-4K technology gives you a much better, clear image of around the liver landmarks, and the right liver is fully mobilized for segment 7 monosegmentectomy. IVC ligament is stapled, divided, and we routinely use Grissom Pringle maneuver, and then we try to take posterior trunk, a little bit breaking parenchyma rather than breaking Grissom sheath. So I always told a young surgeon not to break Grissom sheath, but to break liver parenchyma instead. So now main branch of a posterior trunk is now taped yellow. Then I take segment 6, Grissom and pedicule. Then the segment 7 will be taped by subtraction of main posterior trunk minus segment 6. So red tape is the root of Grissom and pedicule segment 7. Then it was a bulldog clamp, and again, indocyanine green was intravenously infused. We routinely use 0.5 milligram per body. So now the border between segment 6 and 7, and the border between segment 8 and 7. But preoperative simulation revealed that some part of a tumor is kind of fed from segment 8 dorsal. So some part of segment 8 also is going to be removed. So again, border inside the parenchyma can be visualized like a green. This is a real recent overlay technology. So green shining perfusion area and non-perfused area, you can visualize very clearly. So V7, a couple of V7 is clipped and divided. And again, right hepatic vein is fully exposed. So this is a greaser than pedicle comes from a segment 8 dorsal. So we found it, and as you see, this area is perfused because of segment 8. So part of a segment 8 dorsal was also removed. The quality of camera improved. This is the latest version of camera. Then you can clearly visualize the demarcation plane between segment 8 ventral and segment 8 dorsal. So what you have to do is just to try to find the appropriate plane, referring this shining green area and no shining green area. That's intersegmental sectional plane. Intersegmental sectional plane, only hepatic vein exists. Hepatic vein runs across the cut surface or crossing borders. Same thing, and intersegmental plane, only hepatic vein runs, and sometimes crossing the intersectional segmental plane or running along the intersegmental sectional plane. So this is a V6. It's now going to be staple divided. Then you can just using a ligature to divide intersectional segmental plane, because there's only hepatic veins exist, not greater than pedicle, including a bile duct, will never exist that appropriate intersegmental sectional plane. I think this is kind of a whole new concept of a liver resection, in my opinion and in my mind. So segment 6, monosegmentectomy, will be completed. Another way to see a precise intersectional segmental plane is to use 8K, because we've been using a 4K for the last several years. We really appreciate the quality of a video. Even 5mm suction tube becomes 5 centimeter on the screen. So, but if you look at 8K, resolution is 4 times larger, and also 5mm suction become 10 centimeter, so 10 times versus 20 times. So I think we appreciate those high quality of a resolution with a high resolution. Then you see during a parenchymal transection very tiny small structures, anatomical structures, and those structures are crossing intersegmental sectional plane, but we can identify even those structures are vein or small greater than pedicle, including a bile duct. Then I realized this nice plane, appropriate plane, there's only hepatic vein or small structure exist. So we can just bipolar sealed, not using a clip, because if I think there's a bile duct, I always place a clip, but I can realize this is a hepatic vein crossing intersegmental sectional plane, or even small structures like this. Professor Sugioka named it as a kind of a peripheral branch of Laennec capsule. So I'm not so sure if it's true or not, but some structures not hepatic vein or not greater than pedicle exist in intersectional plane. So this vein is crossing intersegmental plane between segment 3 and segment 2. So this is a V3 because coming from a segment 3. as you can see, you just kind of wiping using a CUSA. So wiping, you visualize a small duct, not small structures, not it's the duct. It's only a hepatic vein or peripheral lena capsule. Again, another V3, because I'm removing segment 3. So this vein comes from segment 3. This is the final part of aspect of the surgery. Only a small hepatic vein runs acrossing the segment 2 and segment 3. Then I can use energy devices to just divide it. This is a cut surface. You see many veins and only a small couple of clips, which I thought that's a Grissom pedicule. Then I place it. So this is nicely done segment 3 monosegmentectomy with 8K. So with 8K, I think 8K is only the limit of human visuality, human's eyes visuality. So this is the end points of surgery probably. But at this moment, 8K doesn't have IL technology. So in a couple more years later, we have IL and 8K. So another case, colorectal liver mets, 3 metastases located 2, 8, and 5. And 2, 8 are very much easy to perform wedge resection, but this 5 locates a little bit deeper. So we decided to perform segment 5 monosegmentectomy which consists of 3 cone units, green, yellow, three G5, and also we refer the shape of this area to be resected. So we routinely perform a Grissom approach, Pringle maneuver. Then the anterior trunk is taken. As you see, I don't mind breaking a parenchyma to take a Grissom approach, to take anterior trunk. It's better not to break Grissom pedicule rather than breaking parenchyma. So I'm using a CUSA to visualize a G5. I think this is the main G5. And the preoperative simulation, it was in, I think, yellow. So this was clipped and double clipped with hemolock and metal clip and divided. And the anterior trunk was clamped so that we can visualize a plane between 5 and 4. So we open up a country line 5 and 4 to approach a G5, locates deeper from the hilar plate. So as you can see, this is very nice clear margin demarcation area inside the parenchyma. So anterior trunk, blue dot was removed. Then I found G5 locates deep inside parenchyma. So this is another G5, caudal side of a G5. It also taped and divided. So we know we have 3 G5 to be ligated and then divided. So it was divided. Then now we can approach a G5 deeply located inside. Then it was taped. And I place a Bluetooth clamp. And again, I'll ask anesthesiologist to give a 0.5, another 0.5 ICG per body. Then we're going to see a clear margin between segment 5 and 8 after reperfusion. I think this is very nice. It is very difficult to define segment 5 and 8 border, but when you use ICG like this way, you can clearly see a margin between 5 and 8, and this is a margin between 5 and 6. So I recommend to perform a superficial parenchymal transection along the area to be resected. As you can see on your right side, shining green is segment 8. On your left side, dark side is no green is segment 5. So this is a margin between segment 5 and 8. And the hepatic vein running along the intersectional segmental plane or sometimes are crossing intersectional segmental plane. This is a last G5 located cranial side is now clipped and divided. This is a peripheral right hepatic vein. It's running along the segment 6, and again the border between segment 6 and 8, 6 and 5, and 5 and 8 is now clearly visualized. And sometimes those small veins are crossing intersectional intersegmental plane. So this is very much a precise anatomic resection of segment 5, which consists of 3 cone units. We hosted a very important consensus meeting last month, that was an expert consensus meeting on precision anatomy for minimally invasive HPB surgery. I was the principal investigator for liver minimally invasive surgery, and Professor Nakamura was a principal investigator for pancreatic surgery. So 500 people gathered on the web, and we appreciate the various comments. And this is my presentation. I talked about terminology in Tokyo, and this is also another presentation about Grissom approach. So the Grissom approach is a reasonable technique during minimally invasive anatomic liver resection. So this video showed that Lennox capsule and try to create some space between Lennox capsule and Grissom and sheath, which you can tape from the Hilar plate. So this is first order division of a Grissom approach. I believe every liver surgeon has to know how to perform a Grissom approach. This is a very easy and safer way once you get used to do it. But if you don't know anatomy, probably it's going to be a mess. So please prepare for learning Grissom approach, even for donor surgery in a living donor transplant. So now a small branch, we call it as an anchor, is coming from Grissom sheath, just anchoring in parenchyma, as if the Grissom sheath has to be stayed inside the parenchyma. So this is another recommended definition. Segment 9 definition of the Brisbane 2000 terminology is abundant. And the coded law is redefined based on the portal ramification instead of the spatial recognition. So we did the systematic review of the literature which are available at this moment. We found a couple of papers. The liver area supplied branches from the anterior portal vein should be defined as a part of anterior section and not of the caudate lobe by Kumon. And also in cases with a trifurcated type of portal vein, the caudate portal branches should be ramified from the main portal trunk of the portal vein and not from the anterior or posterior portal vein, also by Kumon. So I think we define the caudate lobe again, not like a segment 9. This is the left side caudate lobe, right side caudate lobe, and the caudate process. It becomes much more simple, much more simple. So this is my team. We perform 1,500 GI surgery a year, including 400 cases of HPB surgery. I'm always thankful to my team. Thank you very much for your kind attention. Please.
Yeah. it was really awesome presentation of segmental resections, the precision and Gleasonian approach. And I think this is the highest peak of what you can learn in the liver surgery, laparoscopic surgery. And as we see with the time, the scope of open surgery is shrinking, and maybe within the not in very near future, we'll be hardly doing open surgery. I mean, this is how it is progressing, and the precision, this 8K and all these new technology, we're going to see more and more laparoscopic, and we have to see how these techniques can be exactly implemented into the donor hepatectomies for parenchymal preservation or modifications. I want Vivek to have a comment on how does he look at it vis-a-vis donor hepatectomy.
Exactly, Dr. Goja, very nice comments. I think this talk was wonderful. It's like pinnacle of laparoscopic liver surgery. Of course, we have been trying to learn laparoscopic liver surgery for a long time now. And I completely agree with you that the scope of open surgery in future should shrink. That is my opinion. It should shrink, and we should train more and more young surgeons for doing laparoscopic and minimally invasive, whether robotic or laparoscopy. That doesn't make any difference, but the training might be slightly different. But of course, the scope of laparoscopic surgery is huge. Patient recovery is much faster. And many studies also show that the liver decompensation in major hepatectomy is also less with laparoscopic liver surgery.
Yeah.
And to answer your second question, how we can transform these into living donor hepatectomy, right?
Yeah.
So of course, as I showed you in my slides, we started doing minor hepatectomies before. So it's about piecemeal learning, how to divide liver, how to use CUSA, how to use energy devices. Once you acquire that knowledge, then you can altogether put that knowledge into pure laparoscopic donor hepatectomy safely. So it's about a trial ride before we go on actual ride.
Yeah, let me reframe what I actually wanted to ask you exactly. Is there a role of Gleasonian pedicle approach in donor hepatectomy, and will it ever be there? And what is your thought on that?
Well, Dr. Sanjay, I think some centers, some surgeons prefer Gleasonian approach for donor also, and some surgeons in the world also do a Pringle maneuver for donor hepatectomy. But majority of living donor liver transplant surgeons, they actually do a proper porta dissection. And because ultimately what we have to do is divide the portal vein, right portal vein, left portal vein. So better do it that way rather than Gleasonian approach. So I don't see much future of Gleasonian approach as far as pure laparoscopic donor hepatectomy.
Hello.
Yeah.
Yes, Rajnikant.
Hi. Thank you, Vivek. I saw your laparoscopic donor hepatectomy. It was a great show of your techniques, and you have achieved the, as you said, the peak of the learning curve. And this one is now Professor Wakabashi showed very subsegmental anatomy very thoroughly and clearly. But for laparoscopic donor hepatectomy, maybe this one is, I feel it's a bit difficult to replicate. What do you think? In left lateral or left lobe, do you think this will be helpful, like Gleasonian approach?
Gleasonian approach basically is to make you comfortable in transaction. That is one thing, right? So even if we do Gleasonian approach, you have to divide all pedicles separately later on at the end of surgery. So most of the living donor surgeons would prefer to dissect the vessels and bile duct before rather than do a Gleasonian approach, which might be good for tumor surgeries or resections. But for living donor liver transplant, I think that is not a good approach.
Okay. Thank you. Thank you, Vivek.
Vivek, if there is time, can I ask one more question?
Yes.
Yeah. you see, there's a one question somebody asked me once. There are two donors. One is a donor who has a lot of fat, you don't want to take. Then there's a young donor, but his remnant is like 27, 28. Okay, the other guy is. So which one will you prefer? Why I'm asking you this question is there a way? There's a paper by Makuchi which he said that you can preserve the segment 8 towards the donor to increase the donor volume. So do you think that the Glisonian pedicle approach will have a role in vascularized parenchymal preservation in the donors if there is a marginal donor like this guy who's like 26, 27 remnant percent?
I don't think so. I don't think so because um, ultimately what we are achieving is, I know what you are asking, that if there is a marginal remnant volume of about 28.5%, then we can preserve the pedicle of segment 8 vein. But what use is that if that pedicle is coming from the right portal system or right portal vein or right hepatic artery, because anyway we are dividing them extra hepatically. So preserving them intraparenchymally would not make any sense. More important than that, what we follow in our technique is to leave around 1 centimeter of parenchyma and not do anatomical resection in such cases. And it seems that it works very nice because the retrograde oxygenation or flow from the middle hepatic vein keeps in preserving that parenchyma.
Thank you.
Thank you.
All right. Thank you, Chairperson. Thank you, Dr. Goja and Dr. Pacha. We're going to move to next session. I would like to invite Dr. Kausar M.I.C.E, who's a senior transplant surgeon at AILBS, to moderate the next session.
Good afternoon. For the next session on selection and surgical planning of the laparoscopic liver donor, I would like to invite Dr. K.R. Vasudevan, who is the Director of Department of Liver Transplant at PSRI Hospital, and Dr. Puneet Dargan, who is Senior Consultant, Department of Liver Transplant at Fortis Chennai, as chairpersons.
Good afternoon, everyone. It is said that without a route map, it is not possible to reach your destined destination. So now I would invite Dr. Vishal Chaurasia, who's a senior, versatile, and a gifted surgeon at the Fortis Group of Hospitals in NCR, to tell us about his surgical and patient selection plan in the next few minutes. Thank you.
Very good afternoon, everybody, and thank you, Dr. Puneet. As we all are aware that we'll be discussing step-by-step laparoscopic surgery steps. So to put up as a prelogue, I would like to put up the case that we'll be discussing in the subsequent steps. Along with that, I would like to touch upon the basic selection criteria which we use for selecting the case for donor hepatectomies. So this is the basic donor selection slide that we all are aware of, that he should be a family member within the age group of 18 to 15 years of age and should have a compatible blood group and overall should be a very healthy as on medical evaluation. Although with newer techniques of incompatible AVO liver transplant, the same or compatible blood group might be not be that relevant, but still in majority of cases, we do prefer that a compatible blood group is always a preferable idea. However, the basic premise or the basic the idea of lab donor surgery have probably been evolved out of the three basic emotional mechanisms, be it the empathy towards your patients, be it as a little bit of compensation to the altruistic donor, or to achieve a surgical high, which is the largest epitome of laparoscopic or liver surgery. So it's either in a combination or in exclusion, these emotions have given somewhere rise to the development and progress of laparoscopic liver surgery. And since the very purpose of development of lap liver surgery was arise out of these emotions. So as Dr. Vivek has previously also mentioned that exclusion criteria should ideally not hold promise in the near future. But traditionally, yes, of course, there will be hitches for every program with regards to variable vascular or biliary anatomy, whether it's because of the graft volume. Many centers do not prefer laparoscopic surgery if the graft volume is more than, say, 900 grams, or based on graft type, like a right posterior sector graft might not be a very good option to proceed at, or in the presence of any developmental anomalies like left-sided gallbladder or a right-sided round ligament to be precise, or in cases of type D portal vein, it could be very tricky to offer laparoscopic surgery at the inset. But this does not undermines the role of exclusion criteria, because exclusion criteria are very important, especially at the early part of the learning curve. Not only to avoid early disappointments, but also to avoid accidents. But these, as experience accumulates, these factors might lose their relevance in the once you achieve and plateau in your learning. So these factors might not be that relevant. So to start with, whenever a new program is started, there can be relative exclusions in terms of variable anatomies, like presence of multiple inferior veins, multiple arteries or portal veins, multiple ducts, or a complex hilar anatomy, or larger liver volume, say more than 800 or 900 grams can be a little bit, centers might be having a hitch to operate on these patients as pure laparoscopic donor hepatectomy. But exclusions can be discriminatory, but although it not ought to be. So to cover up these, you have to keep a, and the basic idea of development of laparoscopic surgery was to ultimate epitome is to apply it to everybody. Okay, so, but there should be a very clear balance between universal applicability and patient safety, which should be maintained and should not be compromised at any level. But as we all know that to do this, you need to evolve. You need to evolve your techniques. You need to evolve strategies, because it is only with evolving knowledge and experience that you can exclude the exclusions. Okay, but evolution do comes at a price of huge experience in the specialty, be it surgery or anatomy, and keen observations and understanding of the science, especially relevant to the laparoscopic surgeries, are the mechanics and the optics. And of course, the dedication and the sheer patience. And last but not the least, the conviction that it can be done, because unless you see it, you cannot do it. So various evolving strategies are important, not only to overcome your own handicap, but to overcome the anomalies, overcoming the technical limitations that happen in laparoscopic donors, to prevent complications or accidents, and overall to improve overall results and make it comparable to open donor hepatectomy. You need to evolve, continuously evolve and evolve. I would like to cover a few strategies that we do have evolved over time to cover up certain anatomical problems, like for inferior hepatic veins, which usually cause a shadow effect because of their obstruction. The dissection caudal to inferior hepatic veins is very difficult. So you need to overcome it with a flexible camera head, which offers a very good technical advancement. What we call it as a peep over fence dissection. You just need to peep over the vein, caudal to the vein, to dissect the remaining of the IVC, which is otherwise not possible. If you don't have a flexible camera head, then the strategy has to be different. With a rigid camera, you need to progressively keep on dissecting the triangle of IVC to expose it in a way that you keep on raising the altitude. We can call it as a progressive altitude raising mechanism or dissection. Similarly, for bile ducts, we have evolved various technical strategies like Hilar plate first incision, and especially in cases of type 2 bile duct division, we decide on whether to loop it as a single duct or a different duct based on the angle between the two ducts. If the angle between the two ducts is less than 45 degrees, it is not sensible to loop them separately. It's always better to loop them as a single duct, because otherwise you can injure the two ducts. So these technical advancements or knowledge, or this comes with your gradual experience that you accumulate over and over time. And if required, we are very open. If still the anatomy is not clear, then the best option should be to free cut and suture the ducts. So you can very well see a suture line, which can be very well replicated like as in the open surgery. So if you need to evolve, we need to be very well acclimatized with the suturing and the suturing technique as well. So as of now, as a departmental criteria for lab donor, we do not offer any exclusion criteria. All donors who consent for laparoscopy are taken for laparoscopic donor hepatectomy. Few exclusions criteria which relatively we follow as of now, but we never know that in near future it might become redundant, are that we had not yet operated on a right post resector graft laparoscopically. And secondly, any incidence of type D portal vein with or without left-sided gallbladder. I am specifically mentioning this too because we have a successful series of operating on these patients and retrieving the graft successfully and via the open technique. So we have not yet encountered these anomalies after that, so that we can see whether we can offer this laparoscopically or not. So with this, I would like to proceed with the case which will follow, which will form the base for the next session, next interactive video session. So the case, the video of which will be shown and in detail in the next session is of a 43-year-old Syrian female with a BMI of 28.95, who was the wife of the recipient. She was medically and surgically fine, was a multipara with regular cycles. There was no addiction for her. Her biochemical profile was completely normal as per what is required of a donor. As we can see, she had normal thyroid function test, viral markers were negative. She was immune for CMV. Cardiopulmonary and gynecological evaluation was completely normal. And coming up to what is important for liver perspective, she had a liver attenuation index of +13, which is perfectly fine. The arterial anatomy was replaced RHA, which was arising from superior mesenteric artery. Portal vein was type A, that is standard. Venous anatomy, MHV anatomy was pretty standard. There were no inferior accessory veins. CT volumetry shows a right lobe graft without MHV to weighing about 964 grams, which was giving a GRWR of 1.07 and remnant was 40%. The graft plant was right lobe without MHV. As per departmental policy also, we don't prefer to take MHV with the graft. The MRCP revealed a type 1 biliary anatomy. The surgery planned, as we know, is pure laparoscopic donor hepatectomy. The graft was planned was right without MHV. So the subsequent surgery will be discussed in the videos, which will are as AILBS videos, which are very well available in the program in set. And we'll be discussing these as different topics like patient and port position, liver mobilization, IVC and retrohepatic dissection, port artery dissection, liver parenchymal transaction, and division of bile duct and hilar plate. All but the first session, all but the first video, that is the patient and port position, is of a different patients, because somehow we could not get the patient at port position video of the same patient. But before proceeding to the video session, let me just conclude my case presentation with the surgical outcome, because we might not get the time to reveal that in the end. The graft weight which was retrieved was 926 grams, which was about 38 grams less than the predicted value. The warm ischemia time from arterial clipping was 5 minutes and 10 seconds. Blood loss was approximately 800 ml, and no transfusion was given, either of blood or blood products. Camera port to graft out time was around 245 minutes, and total surgical time was 280 minutes. The post-operatively, the donor recovered very well and was discharged. We can see the bilirubin on day 7 was 0.038. The peak SGOT-PT were 114 and 105 on day 1. Post-op recovery of the recipient, because as rightly Dr. Vivek mentioned that it's of no use of doing donor hepatectomy if we can't replicate the recipient very well. So we can very well see that the recovery parameters of the recipient's bilirubin was 2 on day 16. It actually, there was an increase on day 12 because of insufficient immunosuppression, which settled down with increasing the dose of the CNIs. And the maximum OTPT rise was around 273, and PT rise was 214 on day 3, after which is declined subsequently. This is the outcome pictures of the donor. Both donor and recipient had uneventful recovery, and donor was discharged successfully on 7th POD and recipient on 16th POD in stable condition. With this, I would like to conclude my talk. Thank you.
Thank you, Dr. Vishal, for giving us a brief outline of the patient selection and the roadmap for pure laparoscopic donor hepatectomy. Dr. Vivek, will you like to add something before we go on to our next segmental video presentations?
Not really. Very nice presentation, Dr. Vishal. I think you highlighted the core of doing pure laparoscopic donor hepatectomy. That core is emotion from the surgical team. Yes. I really like that slide saying that somewhere, somehow we have hidden zeal of making benefit to the donors. I think that is the inspiration of doing pure laparoscopic donor hepatectomy. And as you rightly mentioned that many centers who are embarking on their journey to pure laparoscopic donor hepatectomy, they should start by strict selection criteria, mentorship. They should visit programs who are already doing it, so that the relearning becomes simple. It should not be learning again and again and again and again. We should pass on the knowledge to people who actually want to do it. And third thing is, of course, once we have bits and parts of knowledge about how to use QSA in laparoscopy, how to use energy devices, how to mobilize, then of course we can directly apply all these knowledge combined together to laparoscopic donor hepatectomy. Sure. Thank you so much.
Thank you.
Any questions from Dr. Vasu?
Yeah, Shal, that's a very nice presentation. For the benefit of people who would be embarking on laparoscopy, can you kind of allude to the fact that which are the problems you tend to tackle first along your journey in the selection criteria or in technicalities, whichever way, and which are the ones to leave for the last?
Look, actually, what we have been doing, what we had a very long journey with laparoscopy. Actually, initially we started the biggest problems that I think which is common to all and which comes to the mind is how to lift the liver, which is the biggest problem. So initially we also didn't had any know-how about how to do it. So we started off somewhere with a hybrid kind of approach. This subsequently, gave up proper learning, and then we visited the Korean center, Korean University, and then obviously gradually our learning had improved. Selection wise, from the very beginning, we were not very keen on selecting the patients based on anatomy because we didn't want to lose learning from any of the patients, because we followed whatever steps we could make use of. Suppose if we had a patient who had given consent for say laparoscopic donor hepatectomy, and which had a complicated hepatovenous anatomy, then we would like to go ahead and perform maybe portal dissection for that patient. So at least we can make use of the opportunity to learn the portal dissection in that patient. Okay, because obviously that any dangerous steps, usually if for a beginning program, I would like to suggest that the most dangerous step in donor hepatectomy is the IVC, because it is one step that you need. There's no way, if something happens, it can also be dangerous to the patients and you need to convert. There is no way you can proceed without opening or without converting. If there is a bleeding, okay, you might open, but still this is the most dangerous step, and which can be having serious consequences for the patients. So IVC has to be very precise, which is one step which is very, very important. And I don't want to say that you can keep it for the end to learn. Don't lose the opportunity for learning whenever we can learn. Okay, but we should not be very much optimistic without a reason. Obviously, we should learn now, since it's no more an experimental procedure now. Very well, a lot of centers are doing it. So it's always good to adopt practices what have been successfully established by the masters. And that's what have helped us also in proceeding to the level that we are today. So I think that should give you what you have been asking for, Dr. Vasu.
If I get it right, keep trying, be safe.
Yeah.
Don't leave anything for the end.
Yeah, exactly.
Thank you so much.
Thank you.
Now for the next topic, I would like to invite Dr. Kaleem, who will moderate the session on position and port placement.
The people who have joined virtually can also send their questions on the chat box, type in, and we'll get the right people or the chairpersons or experts to answer those questions. Thank you.
Our next session is patient position and port placement. And for this, I would like to invite our chairperson. Our chairperson for next session are Dr. Bipin Vibhuti, who is Program Director of Center for Organ Transplantation, Shadri Hospital, Pune, and Dr. Balachandran Menon, who is Director Liver Transplant HPV Surgery, AIG Hospital, Hyderabad. And I would like to request our chairperson to proceed with the next session.
Thank you very much. With this, first of all, I would invite this AILBS video of port placements.
I think positioning of patient is very important as it gives you comfort. While because it's a long surgery, you stand up and uh, along with your first assistants and second assistants and scrub nurses. So proper positioning of patients to avoid any post-operative back pain or anything else is very important. We use reverse Trendelenburg position for these patients and special stirrups, which can be, these are hydraulic stirrups which can be manipulated from outside to to change the positioning or height of the legs. Sometimes when we operate on laparoscopy, the leg, we don't get hand or space between instrument and the legs. So in those cases, these hydraulic stirrups are very useful. We can lower them and create a space for manipulation of instruments. So we use, after marking of suprapubic incision site, we use open technique for putting a camera port, which is the first port used at the umbilicus. We don't use Very's needle. It's a camera port, which is a 12 mm port. And we routinely use disposable ports for the same, although they are very expensive. You know, if we use all the disposable ports in single patient, then of course, the cost becomes around $1,500. So one has to innovate, use different kinds of, you can use metal ports, you can reuse these ports if required. So after putting on the umbilical port, pneumoperitoneum is created. Initially, I must mention here that initially in our initial experience when we used to do started doing pure laparoscopic donor hepatectomy, it used to take about 2 to 3 hours for patient positioning, because that was a learning phase. Everybody is learning. Your scrub nurses, your technicians, your surgeons are learning. So it used to take us 2 to 3 hours to position the patient and place the ports. There's a lot of time and learning goes in the initial period. But later on, now we are down to around less than half an hour for patient positioning as well as port placement. And this is a kind of an unedited video of port placement, which is around 10 to 15 minutes. That's it. So the second port we place, we divide the ports into various types. On the left side, we use working ports. And one working port is placed in the mid-clavicular line, 2 to 3 finger breadths below the margin of the liver. So you actually have to see the margin of the liver. If the margin is going too low, then you have to go lower. This is the second port, which is again a 12 millimeter port. And the third port we place is either an anterior or a mid-axillary line. And this port has to go, the positioning of this port is actually based on the Riedel's lobe. If the segment 6 is going too low, then of course we have to place this port slightly lower. But every case is a different. I must say that port positioning is an art which you slowly learn over the time, because in this surgery, when we use these two ports, which are working ports, there's a lot of fatigue which happens on the arms and fingers. And with slight changes in the port placement, you can actually avoid that and slowly progress. And the assistant port we place on the right upper side, which is again a 12 millimeter port. This can be a 5 millimeter port, but I usually prefer this as a 12 millimeter port because I use all the 3 ports for vascular staplers. For dividing the right hepatic vein, I use this right assistant port. For portal vein, I use left-sided working ports. So some surgeons use 5 millimeter port, and depending on their comfort, but I prefer these all ports to be 12 millimeter ports. After these 4 ports are placed, the falciform ligament and umbilical ligament is divided with the help of energy device. Any energy device is good, either Thunderbeat or Athicon HT 1000 is good enough. This is in preparation of putting up the fifth port, which is usually a 5 mm port in the epigastrium, and that port is used for suprahepatic caval dissection, and that is a very must port. And another utility of that port might be, once suppose some patients have large BMI and we are unable to reach the top portion of the liver from these working ports, then of course we can use that port as a CUSA port, and the mid clavicle line port as a energy device port to reach the upper portion of the liver. So once the inset is showing that we are just dividing the falciform ligament, and after we divide the falciform ligament, then we place our 5 mm port in the epigastrium. Below the xiphisternum, it's a midline port. So this port directly peeps over the suprahepatic portion, and we can use energy devices like harmonic or thunderbeat to dissect the right hepatic vein and the coronary ligament on the upper side. So this is how the final position of the ports look like, which might be slightly different from other centers, but we are comfortable with these positioning of ports. If the patient is too big or large, if the cavity is too small, then you can vary these ports, because if the cavity is small, all the ports will clutter. Thank you so much.
That was an excellent video. Port placements are probably the most important part.
Yes.
The better the port placement, more easy the surgery. It's like a 100-meter race where you're starting from 30 meters.
Yes, Dr. Bala.
So I'm sure there are a lot of questions. I think we should take all of them at the end. So with this, I invite Dr. Lee, Professor of Surgery, Seoul National University. He hardly needs any introduction. Most of us have seen him operate, and there's a lot of fan following of his in India. So he's going to talk on science and engineering of port placement. Over to Dr. Lee.
Unfortunately, Dr. Lee couldn't join live, but he has sent his video recorded presentation. Can we have the video, please, for Dr.
Good
Lee?
evening. I appreciate Dr. Viju and the organizing committee of AILBS for the invitation. I'm pleased to share my experience in laparoscopy living donor hepatectomy, especially focusing on port placement. I personally prefer the thotomy position, and during operation, reverse Trendelenburg position with right side tilting. Reverse Trendelenburg drops down the bowels and take it away from the surgical view without a further traction. Right side tilting enables the operator to manipulate the main working port ergonomically. We use 5-port system, and the main surgeon is located between the patient's legs. Let me present the details of science of each port placement. Camera port here is mainly for camera walking, but sometimes it is used for stapler application. So determination of location of camera port, we have to consider the distance between umbilicus and the dome of the liver. Let's move to the operator port here. We use 12 millimeter size trocar, and we use energy device, Goldfinger, bipolar, and all other devices. Usually used for liver mobilization, but sometimes it is alternative walking port. The determination of location, we have to consider the accessibility to the superlateral side of the liver for mobilization and the hepatic hilum. I prefer to place the operator port L at the anterior line of right side axilla. If we select little backside of the patient, it's easy to access the lateral side of the liver. However, sometimes it can make collision between operator left side hand and the patient leg here. If we select more medial side, it's difficult to approach lateral side or upper side of the liver. If we select lower side, it's difficult to approach the upper part of the liver. If we select little higher, just below the rib cage, port itself can make a liver injury, and also the Hilar structure is located in horizontal level. That's why sometimes it's difficult to approach the hilum. This is the port placement video. You can see the location of the tip and the direction of the operator port L. Liver tip is here, the gallbladder and the Hilar structures here. During right side mobilization, I insert the energy device via operator port L. Together with operator port R, the liver mobilization is quite easily performed and also safely, and also ergonomically is good for the operator. Now let's move to the operator port R, right. So its main working port, this port is used for Hilar dissection as well as dissection of middle plane of the liver. To determine the location of port, operator port R, we have to consider location of middle plane of the liver, that is a dissection plane, and the location of gallbladder, that is the main landmark of Hilar structures. For the operator port R, I prefer to select this position several centimeters away from midline here. If we select more right side, it's not good for the operator's ergonomics, especially right wrist is too much angulated. If we select midline here, the cursor will approach from the right side, left side of the dissection plane. If we select lower side, It's difficult to approach to the upper part of the dissection plane. If we select little higher, sometimes it's difficult to access the hilar or ergonomically bad to access hilar structures. This is a video of operator port R insertion. You can see the ergonomics of the operator hands. Gallbladder is here. This is the insertion site. Middle plane of the labia will be located here. Using operator port R, we can make a demarcation of middle plane of the liver with ICG camera. And for the dissection of the middle plane, the assistant holds the counterpart and shift the middle plane of the liver to the little left side, and the middle plane of the liver located just below the operator port R. Let's move to the gyroid port. This is for liver mobilization, especially upper part of the liver. For the operator, however, mostly the assistant uses this port. The location is just below the gyroid, and the better position is higher as possible. This is the video of gyroid port insertion. This is a gyroid process. Just below the gyroid process, the 5 millimeter port is inserted. Here. And it's used for liver mobilization, especially upper part of the liver. So main operator, they insert energy device through the gyroid port, and the left hand of the operator is located at the main working port R. During hilar structure dissection, the suction irrigator is inserted for the assistant. And the other assistant port is here. So the determination, we have to consider only assistant ergonomics. They're usually here. We have to consider ergonomics of the assistant. The tip of the port should toward to the hilar structure of the liver. It's used for assisted duct traction during hilar dissection. Or the counterpart traction during caudate lobe dissection. Thank you for your listening. I hope my presentation is helpful for you to improve your surgical skills in laparoscopic living donor hepatectomy. Thank you.
Thank you, Dr. Lee. That was quite educative. Now, I'm sure there'll be a lot of questions. Let me start with one for Dr. Vij itself. when you put the camera port in the midline, supraumbilical,
Yes.
do you sometimes face difficulty that hanging portion of the remnant umbilical, the umbilical, the ligament
Calciform.
in the way? So have you ever considered putting it a little bit to the right of that?
Really no, because although the ports are flexible, the camera is flexible. So if there is a hanging ligament, actually we can from different kind of ports. You have 5 ports, right? So if you put the first port there, and you can actually sometimes use other ports to show that hanging overhanging portion to dissect that off or to remove that portion. So in practice till now we have put it in only in the midline. Actually what matters is its distance from xiphisternum, which should be around 15 centimeters. For obese patients we place it slightly higher. For thin patients you might have to go slightly lower than umbilicus. That actually is the more important thing rather than shifting it to right side or left side in our experience.
Which system are you using?
So we are using EndoFlex-I 3D, that is system by Olympus, in one hospital. In other hospital, we are using a STOR's rigid camera 3D system. So we now have comparison of both also. So we have been able to do pure laparoscopic donor hepatectomy on both the systems, but at some points we feel both have advantages and disadvantages. At some surgical steps we feel that rigid system is not that useful, especially doing a cava dissection on the top side, looking in the corners, looking at the veins uh, from a perpendicular point of view, from the bird's eye view. That is not possible. So you with a rigid system you see the things, you know, tangentially. Then you can actually not make how big is the vein, what is the upper border of the vein, so all those things. But we can actually steer the surgery accordingly. Assistant can depress the liver, so there are a lot of maneuvers we can do to uh, to do pure laparoscopic donor hepatectomy with a rigid camera also. But ideal is EndoFlex-I 3D system by Olympus.
The EndoFlex one has a 0-degree scope, isn't it? Which
No,
needs
they have a flexible scope too, so we routinely use it. EndoFlex-I 10 millimeter flexible scope.
Do you use the gallbladder for any sort of traction?
Yes, of course. While liver mobilization, the assistant port, which is on left side of the patient, is usually used. The gallbladder can be grasped and liver can be retracted to the left side. The upper 5 millimeter port can also be used sometimes. Both of these are assistant ports. I think the gallbladder is a very good structure to give traction to the liver for mobilization.
If there is a overhanging left lobe, do you need to put in extra port sometimes?
Not really. Not really. We use rubber band technique. While transaction, we can actually tighten the rubber band and it separates out. So assistant is a very important, assistant ports, especially the left-sided mid clavicular port, which goes above and towards the left side of camera port. From that side, assistant can actually maneuver a lot of things. And we never used to have, we never had a problem with overhanging left lobe, and we never put a new port for the transaction or mobilization.
Any other questions from the audience?
So I think, well, if there is no question from the audience, I would like to say something on just a port placement. Like Professor Lee said, there is nothing ideal. Every patient is different. We just need to have some principles of how to put ports. The size of ports doesn't matter. Means we should not be adamant in mind that we have to put 5mm port, 10-12mm ports to begin, because that gives us leverage. The basic difference between robotic surgery and laparoscopic surgery is degrees of freedom, right? So in robotic surgery, we can use one port and move our hand in different directions and angles. But with this laparoscopic surgery, if we have different ports, then we can use these ports as measure of as a measure to do different degrees of freedom. If it is not moving from the left side, we can use it from right side, from upper side. So degrees of freedom are, I think, with robotic surgery from the single port, but different ports, optimal usage of these ports, we can create different degrees of freedom to do different parts of donor hepatectomy.
I think Dr. Krish Menon has a question. Please, Dr. Menon.
Hi, Krish. Can we can't hear. Dr. Krish?
Yeah, can you hear me?
Yeah.
Thank you. I think it's an excellent discussion you had. I just wanted to make a couple of comments.
Yes, sir.
And just wanted to say that first one is with regards to the Olympus versus the Karlstorff system. And I think I completely agree with you. Having used both systems, I think the Olympus one is definitely superior, particularly when you're getting around corners. And we all know every liver, every patient habitus is different. And the access that Olympus flexible one gives is much more than the rigid one. The second point, which is very good that you make, is about the ports. And one shouldn't be hesitant in adding a port or increasing the size of a port for convenience, because end of the day, that little bit of extra access that you get with the degrees of freedom as you described is what makes your life easier. And not to forget, compared to the robotic, I think the haptic feedback you get with the 3D system is incomparable with the robotic system, which is why sometimes when you see the robotic surgeons, you will see tissues being torn because there is no haptic feedback. So just a couple of comments on that. Thank you.
I think very apt comments, Krish. On that haptic feedback, we also initially thought that we will do robotic surgery, but with the absence of this haptic feedback, initially we tried, and we noticed that when we handle the portal vein or structures, then we actually don't know how much pressure we are giving. And in fact, when we did converted from robotic to open, we later on saw that the intima was damaged and there was a clot in the portal vein. So although that is an initial or beginning process, later on we learned that how not to handle the portal vein. But with laparoscopic surgery, such good instruments like DeBakey's are available. You can use it with a haptic feedback, pressure monitoring, and you can actually do it very much like open surgery rather than getting around on a different path.
One last question, Dr. Vich. For closing the bile ducts after transection of the hilum, so which port do you actually prefer?
It's basically the working port. It's a mid axillary port, which is mid clavicular port, which is more preferred by right hand surgeons. Left hand surgeons might prefer anterior axillary line port, like Dr. Vishal is left handed, or he uses both the hands, but his left hand is dominant, so he prefers using anterior axillary line port for the same. Sometimes patient's body habitus is like that, we might use assistant port in the mid clavicular line on the left side for suturing. So these three ports, of course, the most common port being used is mid axillary, the dominant right port. Yeah.
So thank you very much. That was an excellent discussion.
Thank you, Dr. Bala.
Thank you, Dr. Vivek. Thank you, Dr. Lee, and thank you, our chairperson. Now we are closing this session and proceeding with the next session. And I would like to invite Dr. Ajitab Srivastava, who is senior consultant, liver transplant, our liver transplant team. So, Dr. Ajitab.
Thank you. Now let's take the discussion forward. And to have the next section, which will be on liver mobilization, IVC, and retrohepatic dissection, which we will have our video followed by a talk by Dr. Kim on difficult IVC tips and tricks. So let me invite the chairpersons for this session. We have with us Dr. Ravi Mohanka, who's head of the Department of HPB and Liver Surgery, Gleneagles Global Hospital, Mumbai. And along with him will be Dr. Ruslan Arkinov. He is a head of Liver and Pancreatic Surgery and Transplantation Department, Moscow Clinical Scientific Center, Russia. So let's start with our video. Yeah, have they come?
So as I mentioned earlier, also we prefer the Ziffy-sternal port for mobilization of the suprahepatic cava and the upper portion of the right coronary ligament. So we use various kind of energy devices. You can use monopolar hook. You can use either thunderbeat or harmonic to mobilize the suprahepatic cava. Sometimes after mobilizing as much as possible from the upper side, then we go to lower leaf of coronary ligament and try to find the caval plane. Liver right lobe is mobilized. You can use various kind of retraction systems while mobilizing the right lobe. So once we reach the caval plane, all the areolar tissue is taken down with energy devices. Now, whether we ligate some veins or burn or seal some veins or clip some veins depends on personal choice. But generally speaking, the smaller veins can be safely sealed with the energy devices. Cava, loose areolar tissue can be cleared from the cava. And up to 5 millimeter blood vessels can be easily sealed. If you have doubt, you can clip the caval side of the vein, and then the upper side you can thunderbeat close to the liver capsule, because that will give you leverage to manipulate later. So the whole right lobe is lifted. So the lifting of right lobe is usually very difficult. Pulling of gallbladder can help in that. Lifting with the mid axillary port using a kind of a finger retractor, which you see very often in our videos, is a very good method to lift up the right lobe. So to remind you, this liver was around 950 grams, and you can see that with experience we can actually lift up the complete right lobe. So the weight of the right lobe is actually not defining or exclusion criteria. So the experience matters. Slowly and slowly we learned how to lift without damaging the capsule or the parenchyma. So we lift from the left side. The assistant can pull the corded process, which Professor Wakabayashi defined very nicely, and we can lift it up. Then the general principles of cava clearance, moving from below upwards or lateral to medial side, they still are there as in open surgery. We use fine dissection with help of the Becky forceps or pickups. We clip small veins and burn them or seal them in between, and slowly lift up the caudate lobe from the IVC. So this kind of fine dissection, I think this is very equivalent or equal to the open surgery. Sometimes we get across some veins which are short and stout veins, and they are difficult to manage. In those times, help of the assistant in opening up the jaws of, grasper, kind of a crocodile maneuver, helps in putting the clips nicely and burning in between them. So this was a kind of a slightly difficult kiva where we had a lot of veins here. We will discuss this point that we sometimes use argon plasma coagulation, although not very frequently, but just to stop surface bleeding. And slowly you go upwards and mobilize the complete kiva. This is the upper portion, which everybody mentions is the most difficult portion. You can actually hook the segment 8 and retract it outwards to mobilize the upper portion. The small vein just below the right hepatic vein. The dissection of these veins has to be very meticulous. I think the motto is to prevent bleeding, because if bleeding happens, it wastes a lot of time. These veins can be taken down, properly dissected. You can clip them, burn them. So these small veins I like to seal on the liver side. So initially, in our initial experience, we used to do rest of the kiva after liver transaction, but now we have started doing complete caval dissection beforehand. So this is the hepatocaval ligament HCL, which is taken down before we do porta dissection as well as liver transaction. Sometimes this hepatocaval ligament do contain a vein, and we use stapler to vascular stapler to seal that vein. So here the flexible camera head is very important. Otherwise, with the rigid camera head, you actually cannot see the upper corner. And once we have done complete hepatocaval ligament transaction, we spot the lower margin of the right hepatic vein. You can see that there is a right hepatic vein. We can mobilize the midline of the kiva where the hanging maneuver will be done or the sling will be passed. So once this is done, you can use blunt dissection on the medial side of the right hepatic vein. Use a kind of gold finger to pass onto the upper side. And we routinely use hanging maneuver for last 20-25% of liver transaction. That makes it very easy. So as we told you that we have no contraindications, a lot of inferior hepatic veins can also be handled with care when we do such kind of surgery. So principles again are same, the superficial to deep, below to upwards. So this was a large segment 6 inferior hepatic vein. So now this is hepatocaval ligament. So here we loop the hepatocaval ligament before firing stapler on the inferior hepatic vein, and from the CT and otherwise we knew that there is a small vein. You can see that vein fluttering. So in these cases we fire a stapler on hepatocaval ligament. So once that is done, the inferior vein was also stapled. Another case with a very thick hepatocaval ligament with lot of liver tissue, and this inferior vein was just abutting the lower border of that hepatocaval ligament. So we actually had to divide the hepatocaval ligament with energy device and then loop this vein. After looping this vein, you can pass the stapler across. I find Echelon Flex as a very good stapler. It can enter the narrow spaces and the suture lines are just perfect. Staple lines are just perfect. So it's a discussion that should we staple these veins before or not. We in our series of patients, we don't find any difference in outcomes even if we staple it before.
Is Dr. Ravi Mohanka on?
Yeah, hi Vivek.
Hi Ravi.
How are you?
I'm good. How are you doing?
So all well. So exceptional video, and I'm very glad that you presented this portion. So I have a few questions.
Yes,
before. First of all, your retraction is really amazing, which is where a lot of us are struggling in a lot of cases. So what are your tricks for that? Second question is, I see that you're not using as many hemolock clips. You're using all metal clips. So why would that? What is your preference and why?
Yeah. So your first question is retraction. As I think Dr. Vishal also mentioned that in everybody's mind, when we start doing right lobe donor hepatectomy, we think that it's so heavy, how would we lift it? So that's why we started doing initially a hybrid procedure with the hand assistance. But later on, there are two parts of right lobe liver mobilization when we do it. First part is freeing it from coronary and triangular ligaments. Now, the approach we use is kind of a minimal touch approach, where from the superior port, which is Ziffy port, we depress the liver with a gold finger. You must have seen a gold finger which was wrapped with the gauze piece and tied. So with that finger, because it's a soft finger now, we depress the liver and do coronary ligament from upper side as much as possible. This is first thing. Secondly, second step is to just divide the triangular ligament, tip of the triangular ligament. You can hold the tip of the triangular ligament, and assistant can actually hold the gallbladder and pull it on other side, and leave the triangular ligament bit long so that you don't avulse the capsule. So that is another thing we do. But don't try to go as high as possible from this side also. So do whatever is comfortable for you. And third thing we do is lift the liver with that same gold finger which was used to depress liver. Just lift the liver, inferior leaf of the coronary ligament, then you start dividing that. Now this approach, when you start doing this, lifting the liver slowly and slowly, you will join the two lines between. Don't try to retract the liver medially and then join the two lines. From below upwards, it will automatically join. And once you achieve that, then the same gold finger can be actually used from mid-axillary port, which is my working port, because that is the best angle to use it. You can actually lift the liver the abdominal wall forms the fulcrum out of it. So lift the liver, and that is the easiest way. And then you use left hand as a dominant hand for dissection. So this is to answer your first question. Second question you said is hemoclips. We use hemoclips, but for the smaller veins like 2-3 millimeter veins, I think hemoclips are very bad idea. Hemoclips are, they are good for thick tissues. They're good for larger veins. For smaller veins like 2-3 millimeter or 4 millimeter, I prefer metal clips much more. They're much more secure as compared to hemoclips, and they take much lesser space. As I told you that some veins are very stout and short. Those are the very difficult kind of veins. And if you use hemologs, you are sure to slip them. There's no doubt that you will go ahead without bleeding. So that's why I just put a small liga clip, metal clip on the cable side. On upper side, you can do anything. You can burn, you can actually organize also. We have seen up to 5 millimeter veins when we cut, we organize, they seal. So that's not a problem at all. So these are the two tips which I like to give you.
One more question before we open it for everybody in the audience. There has been a few papers which describe the dissection of IVC in left lateral position, just like the kidney donors. So have you used that, or what are your thoughts on those?
Frankly speaking, no experience about that. If we use left lateral position, it can be used. That helps liver to fall with the gravity, but I don't see that with learning up to these cases, we don't find any advantage of that. And moving table too much up and down, we really don't like that.
Okay, any questions from the audience? We would welcome that.
Professor Viragji, may I ask the question also?
Yes, Dr. Ruslan.
Yeah. First of all, thank you for inviting me for such interesting conference. And congratulations, it was very good video, very didactic and very clear. I have some questions concerning the time of transaction. You said that the last cases you do first mobilization, hepatic dissection, IVC mobilization before the liver transaction. What was the reason for that?
Yes.
Why you changed your
so Ruslan, there are the basic reason. If I tell you, if we leave the dissection of cava after the transaction, there are two factors playing at that point of time. One is that we are mentally tired at the end of procedure. The cable dissection somehow we find is slightly difficult from the anterior approach because porta is blocking that site. Sometimes there are veins which are small veins which are stuck there. So we find cable dissection at that point of time difficult as compared to doing it before. But the main reason for doing it before is not that. Main reason is once cava is completely clear, the warm ischemia time to remove liver is significantly reduced. Initially, what we used to do was do as much as cava in the initial phase. After transaction, we do some more cava, then we leave the hepatocaval ligament there. Then we fire all the staplers, and in the end, we used to fire hepatocaval ligament. So that takes another 2 to 3 minutes, number one. Number two, sometimes at that stage, irreversible stage, when you have already divided portal vein and hepatic vein, sometimes at that stage, you might delay the firing of stapler on the hepatocaval ligament because of some adhesions or some other problem, which can happen. And as the warm ischemia time goes up, the outcomes of the recipient do suffer. I strongly believe if people say that up to 15 minute nothing happens, but I don't believe that. Warm ischemia time has to be less than 3 to 4 minutes. That is my simple trick of putting 100% outcomes on the recipient.
Thank you very much. That's a very important topic, and I totally agree. And also another question concerning, concerning hanging maneuver, it's really always successful? Is it possible always to do that?
So, if I share my experience of around 75 cases, we have been able to do it in around 74 cases. In one case, we were not able to do it. In that case, after transaction, you can put a gold finger in the plane between cava and capsule and then divide it. But now I don't prefer that. The problem with that technique is there are certain short hepatic veins draining the caudate lobe. You can actually loop them, and when you use diathermy, they bleed a lot. There is a lateral cut. And at that point of time, suturing those veins is a hell of a job, because these veins are actually short, stout veins draining the left part of the caudate lobe. And suturing in a very narrow space might be very difficult. So I always prefer now hanging maneuver. And as I told you in last, we have used it in 74 cases. In last, I think 50 cases we had no problem. So it might be slow progressive, but we should use it. While showing transaction, we will show some videos of hanging maneuver.
Thank you very much. Any other questions from audience?
Unfortunately,
No?
Dr. Kim won't be able to join the conference for emergency surgery. If we have any questions from the audience or in chat box.
So yes, Dr. Vivek, it was like, I think so we did have very good discussion on this topic, but for the like say, since we don't have any more questions from the audience, so just to carry this discussion forward, in certain situations, like say when we are mobilizing the liver, do you have any special consideration for, say, if you encounter a fatty liver? Is there anything different you do?
So it's like once you enter the abdominal cavity and do laparoscopic liver resection, in the beginning you come to know that liver is a bit hard, firm, or soft. So these are different qualities of donor liver. Sometimes donor liver, you pick it up, you kick it, you handle it, nothing happens. But sometimes you touch a finger and the capsule tears apart. Those are soft livers, fatty livers. I think in those situations, you're sticking to surgical plan. As I initially mentioned, that don't force yourself on the liver, go with a plan. Don't retract too hard. Haptic feedback in laparoscopic surgery is very important. So handle the triangular ligament, try to retract from gallbladder and triangular ligament, go slowly, lift the liver up, go in the areolar plane. So these things do matter, but still once in a while you see a superficial capsular tear as well as parenchymal tear, which you can easily take care by just keeping a gauze or putting argon or bipolar diathermy with that.
So the next thing, as we have already mentioned, okay. So
yeah, if you have an inferior vein, large inferior vein,
yes,
divide it at this point, or would you put it off for later?
So we showed the video that at this point of time, while doing cava, we handle all the veins. Whether it is a large inferior hepatic vein, we just leave the right hepatic vein, liver hanging with the right hepatic vein. Even hepatocaval ligament with all inferior veins are handled before. And our data suggests that nothing happens to recipient, or enzymes are not raised, because right hepatic vein is still working. There is the flow reversal happens from these segments to portal vein to right hepatic vein. Nothing happens. So it becomes surgically easy. I don't think so one should persist doing cava if there is a large inferior hepatic vein blocking the view. That is more detrimental as compared to just stapling it.
Just a few comments. I agree with you that hemolog on small veins is actually keeps coming off. You especially use a harmonic nearby, it keeps coming off, and it's really a pain. And second thing, I mean, going up to the right vein and looping actually is quite difficult, and it needs, I think, with each increase, with your increasing experience, you tend to go up, and at some point of time, I think you'd start looping the right vein. So I really appreciate the way you are looping the right vein.
And you have already mentioned that in case of inferior hepatic vein, we do staple it. Is there any different approach in case if we have a hepatic vein which is stout, where it doesn't give you enough space for dissection? Like say it would be a very short and then it would like the traction may not be
See,
possible.
most of the inferior hepatic veins for right lobe donor hepatectomy drain from segment 6 or 7.
Yes.
So in these veins, first step is to clear the superficial part of cava, including hepatocaval ligament. Once you do that, then you have enough space to loop these veins and staple these veins. So that should be the trick.
No, precisely the caudate vein. Like if suppose you have more than usual a large size caudate vein, so is there anything different?
I think
Who? Dr. Menon, Dr. Krish, I think so. Please connect. Yes.
Yes, I think thank you for that. I think it's really enjoyable discussion. I think I like the way you've taken it in steps and the way Vivek has gone about analyzing stepwise the donor hepatectomy. The thing I would add to what Vivek said is why you should do the cava before you start the parenchymal transaction is even if you look at the non-living donor hepatectomy experience, once you start transacting the parenchyma, a heavier liver falls to the other side. Then it's much more harder to then maintain that plane along your anatomical line of transaction. I think you then find it extremely difficult to go around those little branches, then they start bleeding, and it is a struggle. So try and as far as possible, I would agree with him, do the cava first all the way up to the hepatic vein as much as you can before you start parenchymal transaction.
Perfect. I think a perfect point made by Krish with huge experience in laparoscopic hepatectomy. We have the same experience after transaction. If we start lifting the right lobe, it's just impossible. We cannot do that. So we have to do what we have. If we want to clear cava after transaction, it has to be from midline plane between two lobes of the liver. You can't lift right lobe of the liver and do cava in that way.
Any preference on energy device for retrohepatic dissection?
See, most of the energy devices, like, of course, the principles are same, like harmonic or Thunderbeat, which uses bipolar also. But I think the most preferable device should have very thin kind of thin jaws so that they can enter narrow spaces. This is number one. Number two, they should have sealing capacity of at least up to 5 millimeter of vein. And we should actually know the science behind it while sealing the vessel, because if we know the science behind it, we'll be able to deal veins better rather than just burning them away.
Coming on to the last question, like which I feel, in case you encounter a IVC bleed, what would be your approach?
So that's altogether different video and different discussion. But of course, IVC bleeds can be classified into minor bleeds, major bleeds, and near right hepatic vein or just below. So so it depends actually from where the bleed is. If it is from the free wall of the cava, which is already mobilized, my preference is to just put two or three clips and seal the space. You have to constantly ask your anesthetist to be on toes so that you can avoid any air embolism. So once you see bleed, my first step is to inform anesthetist and do necessary steps. Second step is to get a gauze piece on the bleed. Third step is to hold that bleed. If that is a free wall of cava, if we can actually hold it with the forceps, then put 2-3 clips there, and then you can suture it or handle it later. That is, but if the bleed is from cava and you cannot see other side of the bleed, and it is near like caudate vein, then it is a very problematic situation. So in such situations, don't try to juggle around. just leave a gauze piece or piece of surgery cell there, wait, and you can actually complete transaction, remove the liver, and then handle that if possible. So these are my tricks for handling the cava bleed.
I think we will carry on the discussion with the next section, which is the porta dissection, and I will ask let Dr. Ashish Singhal to continue the moderation.
Let's move to the next session on porta dissection. I would like to invite chairpersons, Dr. Viju Productor, who is professor and head, surgical gastroenterology, Jipmer Pondicherry, and Dr. Anand Ramamurthy, who is a senior consultant and head, Department of Surgical Gastroenterology and Liver Transplantation at Hindu Mission Hospital, Chennai.
Hello. Okay, can we start the video? Yeah.
Yes, Dr. Biju. So in this case, we had replaced right hepatic artery from SMA. You can use various energy devices to mobilize the portal structures. The first step, of course, is division of cystic artery and cystic duct. We leave cystic duct bit longer so that it can be later on maneuvered by assistant port to retract it laterally. So when we deal with the replaced right hepatic artery, usually there is a lymph node there which can actually bleed. Once we identify the right hepatic artery in a replaced position, then we go behind that, divide the peritoneum over the portal vein. So this the structure you see below the right hepatic artery is the portal vein. Like in open system, you open up this peritoneal plane, posterolateral to the portal vein, identify the right hepatic artery, dissect the posterior portal tissue. This is the posterior portal tissue. It's very important to dissect this posterior portal sheath. Until you dissect this posterior portal sheath, you will not be able to loop. And while dissecting this, you exactly reach the midline where the portal vein is dividing into right and left branch. You might come across some caudate veins from the portal vein. So if the vein is too small, you can actually burn it with the energy devices. Or if it is not small, then you can leave it. You can maneuver your forceps between caudate veins and leave it to for the transaction on the later in the later time. When we actually divide the portal vein, then they automatically get divided with the staplers. So we loop the portal vein with the help of the forceps. Assistant is holding the cystic duct. He can change the direction of pull on the cystic duct towards upwards, downwards, towards his side, depending on the part we are dissecting. So this is the cystic artery, which is going on the taking off from the right hepatic, replaced right hepatic artery. You can see right artery pulsating underneath. Sometimes porta dissection can be difficult with the replaced and anterior arteries because they are stuck to bile duct. So in those situations, don't try to dissect too much. We can just clear the space between right hepatic duct and the artery and loop it. That's it. This artery was very much stuck to the bile duct, so it took us some time to get this off the bile duct. Sometimes the sheath is very dense between artery and the bile duct. So this is the space between the right hepatic duct and the replaced right hepatic artery, which we dissect. And this space is cleared. I think the constant thinking about anatomy lie during this phase is very important. And feedback from your surgeons, assistant surgeons, is very, very important. So you can see the sling on the portal vein on the lower side. We go and divide the areolar tissue and the fascia. After dissection of the right hepatic artery, the way I do it is define the confluence of the right and left hepatic duct at this point of time. Later on, we find that it becomes a bit edematous, and definition of the right and left hepatic duct becomes slightly difficult. We divide the peritoneum, lift the peritoneum up, call it loading or firing of hilar plate. So it's like usually there is a small vein at the junction of right and left hepatic duct. So once we lower the hilar plate, we mark the diathermy, the transaction plane at the level of bile duct, complete the cholecystectomy. There are certain special scenarios like this, in which there were two right hepatic arteries, and the upper artery, which was coming from the common hepatic artery, was going above the right portal vein. You can see that the artery going above the right portal vein. So these are difficult cases where the position of artery is very difficult to dissect. But once you are mindful that this is the artery which we dissected later, if you are mindful that this artery might come here, then of course you will prevent injuries. Otherwise, while transecting the bile duct as well as the hilar plate, you might damage these arteries. So this is the upper artery which was found above the right portal vein. So we anastomose both the arteries. Thank you so much.
Can we have the chairpersons, please?
Yeah, thank you very much. It was a nice demonstration. And can I have one question?
Yes, Dr. Biju.
So when you loop the right portal vein, there may be caudate branch. One of the problems we may encounter is if we homologue or clip that caudate branch, so then while you introduce the stapler or any instrument, later it may slip or it may
Yes.
get caught up and all that. So do you use homologue or you do not use at all, or
No.
don't divide at all?
Yes, we don't use Hemolock to seal the portal branches of the caudate vein. So if it is about 3 millimeter, 4 millimeter, you can directly seal it with any sealing device. It works very nice. If you are afraid, then you can put a metal clip, small metal clip on the caudate side or liver side. But usually we find that that is not required. What we try to do is not to burn or clip these veins at this point of time. We go between them and loop the portal vein. If that is not possible at this point of time, then of course you can leave it after the transaction. Once you do the transaction, divide the bile duct, then you can easily loop these veins because angles become straight. So that's how we do it. We don't like to clip any caudate branches of the portal vein at this point of time. As you rightly said, the putting instruments, slipping of these clips is a big problem. If in any case you want to do it, just seal them with the sealing devices rather than anything else.
And another question, the second case, what you have shown, the two right hepatic artery, the second artery, the anterior curving artery, anterior to the portal vein. So if I understand correctly, that you have tackled it after tackling the portal vein. Am I correct?
Yes, we tackled it, of course, while removing, but we identified this branch after loop. We identified it initially after looping of the right portal vein.
Hi, Vivek. Sorry, one small question.
Yes.
When we are dissecting, especially right artery from the bile duct, there are small branches coming to the bile duct. Suppose when you lift or inadvertently pull, sometimes you get dissection of the right artery. Is there any tricks how to prevent?
So, Dr. Rajni, at this point of time, if we try, sometimes you are rightly pointed out that there are branches and these are short branches.
Yes.
What we try to do is gently dissect them with the DeBakey forceps and seal them with the either Thunderbeat or a very fine device. So that is what should be done. Clipping at this point of time is not a good idea because clips are usually not that they're not very small, and putting clips there is also a problem. So if in some cases we are not able to separate it, then my advice is just separate the right hepatic artery from the right hepatic duct. After transection of the right hepatic duct, it becomes much easier. The space between the bile duct and the artery, it widens up. And at that point of time, you can actually seal them nicely with all the Thunderbeat or other devices.
Thank you. Thank you.
Can we move to the
Can we move to the next part of the session if there are no more questions? Ashish?
Dr. Ramamurthy, can you introduce our speaker for this session, please?
Okay. Am I audible?
Yes.
Okay. Thanks. Thanks, Vivek, for the invitation. And we now move to the next part of this interesting session. And this is on the management of anatomical variations in portal dissection. And it's my pleasure to introduce Dr. Alfred Cow, who is Senior Consultant, Division of HPB Surgery, Department of Surgery, NUS. He's also a Senior Consultant, Liver Transplant Program, National University Center for Organ Transplantation. And he's an Assistant Dean Education in the Yong Lin School of Medicine, National University of Singapore. So I welcome Dr. Alfred to deliver his talk on anatomical variations in portal dissection.
Thank you very much for inviting me to give this talk to share my humble experience in performing minimally invasive donor hepatectomy. I would like to share my screen now just to confirm that everyone can see the slide. Right. Now, I think Ashish asked me to talk about portal dissection and some anatomical variation, and I quite enjoyed the video that was showed just now with regards to the steps of how it's done. There might be some slight variation in how I do it, so we can discuss about that. Now, I think it's important for us to highlight that we are coming to 20 years of the beginning of minimally invasive donor hepatectomy, so we should celebrate the great milestones together as a community. Recently, I think the Koreans shared the largest series so far in the world with 5 centers combining together, showing the excellent result that they have with just barely 1.8% of conversion rate and with no major issues regards to the donor. At the same time, complication rate remaining low and recipient outcomes are generally quite good as well. I think as far as adopting laparoscopic liver resection for donor hepatectomy, the key concerns are always, are we able to translate some of the MIS skills that we do for hepatectomies into these? And will converting the operation from open to laparoscopic or even robotic increase the risk to the donors? And more importantly, I think it's extremely important for us to be careful about the need to be mindful about dealing with vascular and biliary structures because the graft needs to be implanted. So this is one important difference from doing this for tumor resections that we will highlight later on. At the same time, I think we also want to be careful about balancing the risk for donor and recipient. So I think just now, there was already a very nice demonstration of how normal structures are dissected during the laparoscopic donor hepatectomy. But we want to be mindful that for a successful outcome of LDLT, there are 2 components to it. Not only the donor surgery must be done safely and successfully, but at the same time, we have to ensure that the graft can be taken out and transplanted successfully in the recipient as well. I think as far as donor selection is concerned, we have heard quite well in the beginning of today's session, but my personal preference is still to stick to standard anatomy at this point in time because of the humble experience that we have. And I think this is an important message to everyone who wanted to start MIS program because we do want to ensure that we have safe outcome. So proper selection of donor is extremely important from the portal vein perspective, from the artery perspective as well. And I think while we don't have significant a problem with variation in anatomy, but we have to ensure that we can successfully achieve a long length of hepatic artery. We can consider some anatomical variation, which may not increase the risk to donor and yet be able to successfully have a graft that can be implanted properly. So 2 artery is not an issue, but small artery is an issue. If there is small caliber artery, I think we have to be extremely careful. And all this has to be taken into account when we do the hilar dissection later on. Now, I also would say that while most hepatic vein and outflow is not a major contraindication, but sometimes when there are too many of them, it may become a problem. So for beginners, I think if there are complicated outflows, including a few major hepatic veins and inferior hepatic veins, then we have to be careful about that. Last but not least, I think what remains the Achilles heel in the donor selection is actually the bile duct anatomy. And I am quite particular about it, and I generally would choose standard anatomy. And with the others, generally contraindicated unless the experience has grown. And I think we have seen how the pot placement is done. I won't spend too much time on that. The surgeon stands in between the two legs. Pot placement is slightly different for how I do it. For adult donor hepatectomy for right lobe, I generally have a 10 millimeter port in the epigastric region with two 5 millimeter ports on the side. I do not have any additional ports on the left side for the assistant. And I'll show you how I actually use certain suture ties to help to retract the left lobe of the liver. I think as of all the donor resection steps, extremely important to have careful dissection of the important hilar structures like portal vein and artery will demonstrate easier with the videos. And also can consider the use of Pringles, although that's not routinely my practice. And of course, QSA is an extremely important equipment that I rely a lot on. And last but not least, I think Dr. Vivek has demonstrated quite nicely that hanging maneuver is important. I also routinely use intraoperative cholangiogram to help bile duct dissection. I won't spend too much time on this because I think Fernando will be talking about the dissection of hilar plate and bile duct later on. So without further ado, I'll just share two normal videos with you first. One is actually on a pediatric donor for left lateral sectionectomy. The pot placement as such, and I usually would generally dissect down the hilar plate and put clips and at the same time do intraoperative cholangiogram to really confirm the landing zone. Sometimes there might be a surprising bile duct anatomy. And careful dissection of the artery is extremely important. And I generally like to dissect it all the way down to the bifurcation so that we can get maximal length from the artery for the graft. And that really is important to ensure that the implantation process is easy. Contrary to what has been shared just now, I personally like to ligate the caudal vein branches, and mainly is for the purpose of getting a long length of portal vein to maximize the length that we can achieve from the graft site. And more importantly, from past experience doing major hepatectomy, if this branch is not taken, sometimes it may cause problem while trying to isolate the portal vein. And of course, I use ICG as well to guide the transection plane, identifying the segment 4 from the right side. But of course, this is left lateral sectionectomy, so the transection plane using ICG is not as important, but injecting the ICG now will help us to identify the bile duct later. This is what I meant just now. Maybe I can play that. So to try to maximize the retraction, I actually use just a suture tied onto the falciform ligament and exteriorize it to the left side. And that helps to centralize the liver to the midline that can facilitate transection of the parenchyma. And of course, this is within the parenchyma, which I will not spend too much time because I think Professor Daniel Shiki will talk about it later. But as far as I'm concerned, part of the key steps is actually careful dissection of the orientus ligament to be able to isolate a long length of the left hepatic artery. And that's important, especially later on. I'll demonstrate to you when there's variation in anatomy, we have to ensure that the artery that's going into this part close to the hilar plate is carefully preserved. And ICG clearly can show us where the left duct is. And I'm just going to stop here for the left lateral sectionectomy because my part of the talk should focus on anatomic variation. Now, I also will share with you a little bit about how a normal right lobe is removed from my perspective. Again, I do ICG to confirm the landing zone at the beginning. I put metal clips to do IOC. And subsequently, I do not divide the cystic duct. I lift it up, and that is good enough for me to dissect the artery and the right portal vein. And in order to achieve a long length of the right portal vein, I generally will ligate the caudate branch. And because we are not going to use stapler here, as far as I'm concerned for donor hepatectomy, I don't use stapler in this region. contrary to compared to resection of tumors. I also want to highlight that actually important to get as much of the short hepatic veins as possible off, because that's important for isolation of the right duct later on. All right, so let's move on to the variation of anatomy now. Handling variation of anatomy is, I think it's important from experience perspective, where the surgeon in the situation where as many experience doing complicated donor hepatectomies should derive the experience from doing it for tumors. And careful dissection of the hepatic artery, for example, in the case that was demonstrated, could be a replaced right hepatic artery, two arteries, and all these arteries should get as long length as possible and dissect carefully. And this video that I'm going to show you is actually a replaced left hepatic artery from the left gastric. At the same time, there's also a left hepatic artery. So with careful dissection of the main artery, we isolate the main hepatic artery. And I go on to dissect and clip the caudate branch to ensure that I can get a long length of the portal vein as demonstrated here. And then subsequently we go on to the lesser omentum area to dissect out a long length of the hepatic artery. And so this left lateral graft will have two arteries and one slightly bigger one, which is arising from the left gastric artery. With careful dissection using diatomy and clipping all the small bunches, we can get as long length as possible. And it's important to try to achieve as long length as possible during the process to be able to then allow successful implantation. And this particular donor was ideal for the recipient because the child essentially had a hepatic artery injury during the CASA operation done in another hospital. And this long artery from the left gastric is important for the reconstruction of the implantation later on. And last but not least, I also want to mention a little bit about handling biliary anatomy variation, which I think Fernando will spend a bit of time on this. In my personal experience, while we select the biliary anatomy carefully, sometimes accessory bile ducts can be present. And in this case, in the right lobe donor that I've done, you can notice that there's a broad right-sided bile duct structure after we have isolated the portal vein and artery. And clearly, using intraoperative cholangiogram, this has been identified preoperatively, intraoperatively. And now with ICG, we can clearly identify the right accessory branch of the bile duct. I generally will clip that, divide that, and it's quite a small caliber bile duct. And subsequently, we can now safely sling the rest of the bile duct and divide them carefully. And this is necessary to do so with the complement of technologies such as the ICG system, which can allow us to identify this and do this accurately. In addition, I think it's important for left lateral sectionectomy donors to be aware that sometimes the replaced right posterior duct can come from the left side, and the transection of the bile duct therefore has to be done carefully in order not to compromise the donor duct that's going to the right side. Ultimately, I think I'm a strong believer by allowing our donors who are mostly healthy to really enjoy the benefit of minimally invasive operation compared to having a big scar. While there's still a lot of learning curve that we need to mount, it is important for us to now start embracing this particular technique because it will strongly benefit our donors in the long run. In my perspective, I think for all my pediatric donors, essentially, they are usually done now with minimally invasive. And in adult, unless there is a significant variation in anatomy, we usually will also offer them as an option. But safety must come first. And we should start a systematic approach to adopting this so that in worldwide, we can have a great learning opportunities for that will benefit our patients, and team building is certainly important. But to make this a success, I think it's important to have centers with large experience in minimally invasive hepatectomy and LDLT combined so that we can do this safely for our donors. And with that, I will end my talk here, and I would like to take the opportunity to thank the organizer for giving me the opportunity to share my experience. I'm happy to take any questions that may have.
Thank you, Dr. Kao, for that wonderful talk. Now we invite questions from the audience. So I would like to start off first. I mean, you mentioned that you needed to mobilize the portal vein, and I agree that in left lobe and left lateral segment dissections, getting a length of the left portal vein is necessary, and you have to dissect, and you come across a couple of one or two caudate veins that you need to ligate and clip. But when you are doing a right lobe dissection, then most of the time there is a constant caudate branch that is opening there. Do you still prefer to mobilize it, or would you do the way that Vivek mentioned in his talk?
It depends on the actual length that I can see during the laparoscopic operation itself. If it is a very high up branch, then I usually leave it alone. But if it is in the way and after opening the posterior peritoneal lining and I'm still not able to get a sufficient length of the portal vein, then I might choose to ligate that, and then that will allow me to have a better space to mobilize a longer length of right portal vein. So I think we have to study the scan carefully. I understand from the CT scan, for example, how long the portal vein is. And that's important because sometimes if your right lobe graft ended up with too short portal vein, the anastomosis might be challenging. So on the balance, I generally will try to see if it's necessary to ligate on the right side. But as a routine, I always do it for the left lobe graft.
Thank you.
I think very well taken point. For lateral or left lobes, we also routinely do lengthening of the portal vein, as Anand mentioned. For right vein, his preference is different. This is how he does it, and this is how we do it. I think it's about experience, how you handle things, and later on, ultimately, in the end, sometimes we also have to seal and ligate these caudate veins while
Yep.
firing staplers, but we find it easier at that point of time than initially. So there are various ways. Ultimately what we have to reach is a long right portal vein. So that's what the aim is. You can achieve it earlier or later depending on your experience.
Most definitely, I absolutely agree with that comment, actually. Yeah.
Very nice video. And are you using 3D or 4K?
We have 3D and both 4K as well as the flexible tip. So I choose it accordingly. If it's a very skinny donor, I generally just use a normal scopes. But if it's a slightly bigger size donor, then or the graph is larger and I anticipate that it's going to be difficult to see the space between the right lobe as well as the diaphragm, then I might use a flexible scope. Yeah.
Are these videos on 4K?
At this point in time, no. This one that I'm showing you is not on 4K.
Okay.
Yeah.
And any situation in the portal dissection, you need to use a Pringle while doing the donor hepatectomy, or any advice on that? Because as a routine, our center, we don't do Pringle, or haven't been in situation to use Pringle during the donor surgery.
So generally, I would say that in about 300 over cases of laparoscopic hepatectomy, I don't have a habit of using Pringles. I have not used a single one of them. I don't see that it has helped in reducing. Rather, because I haven't used it, I don't particularly have a habit of using this to reduce blood loss. But I know that there are two camps in the world. Some people are very pro using Pringles, some don't. And I personally feel it's a personal choice to do it or not. Yeah.
Let me ask one question to Alfred. Suppose while doing portal dissection, you are suspicious that artery has dissected. Sometimes we have seen in our experience that there were two cases in open donor hepatectomy, not in laparoscopy per se. And what would be your approach? And secondly, if we accidentally cut there are two arteries and one is cut accidentally, then what would be your approach in those cases?
Okay, I'll take the second question first. If you've accidentally cut the artery first, unfortunately, you just have to live and be able to accept that maybe a significant segment of that will have a slightly longer warm ischemic time. And that's something that I have personally experienced on one case as well. Again, also a 2 artery, and one of them were mistaken as either a ductal structure or something related to that.
Yeah.
And the outcome, unfortunately, will just leave us to need to monitor this closely. But it turns out that the graph was well. And mainly because I think as the 2 arteries go into the Hilar plate, there are communications and collaterals inside, and they're well communicated with one another. So I generally don't think there'll be a long-term problem as long as there's still continuous arterial perfusion. But if we are worried about dissection, and this is a laparoscopic case, I will certainly want to convert this to open and examine that carefully, because ultimately I will have to ensure that the graph is usable. And the extent of the dissection, I've heard of people doing on-table angiogram to try to confirm that, because intraoperatively to try to identify whether the intima has been dissected and so on and so forth might be difficult, and it may actually thrombose as well. So doing an angiogram on table, asking the IR to come in to help may be helpful, or we can actually cannulate the proximal artery and through the contrast and see whether our suspicion is correct. Now, if the dissection is short segment, then we might be able to salvage the situation by removing that part and then use a better portion of the artery to do reconstruction later on. And I certainly don't hope anyone doing donor hepatectomy have this experience, because it would have been quite daunting, I think, to have to deal with arterial dissection with the understanding that the graft may be compromised later on. Yeah.
I agree.
Yeah, Dr. Alfred, I have one more question, your preference. Talking about the left lateral, do we have a clear advantage for Olympus flexi tip over 4K? I think 4K might be a little bit better because you have a better field of vision for lateral, left lateral, I'm telling, not talking about right.
Sorry, you're asking about the camera system.
Yes, yes.
Okay, my preference is really the Olympus system. I think they give a much clearer picture actually. Yeah.
Okay, can I ask a question of Vivek? So you brought up this question of artery dissection, and there have been some proponents of not trying to dissect the artery completely off the bile duct and kind of after dissecting out the right portal vein, put a bulldog on the right side, its structures, and dissect the artery at a later stage. What is your experience with that?
So we are talking in donor, right,
Yes.
Anand?
Yes.
So if we suspect that and confirm that there is a dissection in the right hepatic artery, then of course
No, to prevent a dissection.
To prevent a dissection. Okay. So for donor, we have never done a clamping or bulldog of the right hepatic artery. What my preference is not to dissect the artery at all if it is difficult, and just create a space between right hepatic artery and the right bile duct. That's what we need to do. Usually there are hardly any branches there, and it's a areolar tissue. Once we dissect that, once we divide the bile duct, right hepatic duct or left hepatic duct, then it becomes much easier for artery to be dissected. So I think that's what should follow. Just clamping the right hepatic artery, we can do that, but I personally don't have any experience about that. Third thing I want to say is in open donors, sometimes we have come across 2 cases of arterial dissection while doing porta dissection. So in these cases, what we do is just clamp the artery with a bulldog, do a fast forward transaction of the liver, take it out within half an hour, 45 minutes, and then perfuse it. So we have till now managed to handle both the cases. The recipient outcomes were fantastic. Although the artery length becomes shorter, there's a flap. You have to keep in mind thinking about where the dissection happened, because that is very important. That point where the dissection happened, if you divide the artery distal to that, there is only an intimal flap. There is no dissection at that point of time. Then you can suture those intimal flap to the adventitia. But if you divide the artery proximal to that point, then of course, if you anastomose without cutting the artery, it's bound to block in the postoperative period. So what we do is shorten the artery, suture the flap, and then deal with these two cases. So sometimes you have to go up to second order branches, right anterior and right posterior, and usually the dissection stops there. And many times if dissection proceeds on one artery, anterior or posterior, you just have to do arterial anastomosis with another artery and leave that as such. So I think that serves the purpose most of the time.
May I also ask a question?
Yes, sir.
Thank you for a wonderful talk, Alfred. And Vivek, I have a question for both of you. If I seen in a dissection of portal hepatics, especially hepatic artery, you widely used monopolar coagulation. So in liver resection, usually we don't care because we do not need to preserve the arteries. Have you ever had the problems with this, with monopolar dissection? Especially when you use metallic stent, you may have a distant trauma of arteries. So we use bipolar coagulation usually. May you give a comments on that? Do you think it's safe to use monopolar coagulation in living donor? Thank you.
Alfred, you can answer first.
Okay, I guess it's surgeons are creatures of habits. I guess my habits is with monopolar because I think it is able to allow me to dissect it quite nicely, but I usually don't activate the coagulation until I'm very sure that the tissue is far away from the artery. And on that note, I don't put metal clips around the branches. Therefore, I'm not worried about transmission of the heat or coagulation onto the artery. As far as I'm concerned, it has served me quite well using just monopolar diatomy. And because it's quite versatile and it's just a hook and I can do most of the operations, but I generally don't use other kind of energy device unless it is absolutely necessary. When I started doing hepatectomy laparoscopically, I use ligature, then I move on to use harmonics. But generally, for now, my practice is just a hook and a LACUSA, and the operation can be done quite nicely. And that's my personal preference. Yeah.
In the interest of time, we need to, I think, move to the next session. Thank you, Alfred.
Thank you very much.
We're going to move to next stop on liver camel transaction. Now I'm going to invite Dr. Ajitab Srivastava again to moderate the session. Thank you.
Thank you, Dr. Ashish. So coming on to the next section of the videos, which is on liver parenchymal transaction. It's my pleasure to invite Dr. Krish Menon, who's a consultant liver surgeon, liver transplant and HPB surgeon, reader, King's College University, London, clinical lead, liver transplant surgery, King's College Hospital, vice president and president-elect of the British Transplantation Society, President-elect Great Britain chapter of the IHPBA. And along with him, Dr. Shaleen Agarwal, who's Director, Liver Transplant and HPB Surgery, Center for Liver and Biliary Sciences, Max Super Speciality Hospital, Saket, New Delhi. So are we connected? Dr. Krish, Dr. Shaleen?
Yes, thank you.
For the very kind introduction.
Okay, so the session will go along with a video of our video, followed by a talk by Dr. Daniel Cherky on parenchymal transaction and management of bleeding. So let's start the video.
So after porta dissection, the ischemic line is marked by clamping the right portal pedicles with the help of bulldogs. So here I think there are certain important tips that as posteriorly we go, we have to go just medial or lateral to the middle hepatic vein. So in this case, there was a crossover pedicle, the in between V-shaped area, and behind you see that this pedicle was coming from the right side. and going across on the left side of the middle hepatic vein. So we routinely use rubber band technique because we feel that it provides the dynamic retraction. Superficial part of the parenchyma can be easily divided with the harmonic or thunderbeat, and the definition of this superficial part of parenchyma depends on surgeon to surgeon. We usually keep it to 0.5 to 1 centimeters max. As we go into the deeper planes, we make middle hepatic vein and branches as our guide and keep on transecting. So while doing this case, there were some points of bleeding. That's why we selected this case. Although majority of cases, there is hardly any bleeding. Some livers are soft and difficult to cut. So this was one of the crossover veins from the 5 side to the left side, which was ligated. And of course, it's very important to study the reconstruction images beforehand. It'll be wiser to have packs in the operation theater. So in this case, the segment 5 junction with the segment 4 junction bled. So we don't have to panic. We just have to handle that. With the CUSA, we dissected the segment 5 vein. With the other hand, we just blocked the bleeding point, loop the vein, once you loop this vein, the bleeding will stop. Then you lengthen this vein with the help of CUSA. Put a hemolock clip on the middle hepatic vein side. My preference is to put one hemolock, a second 200 Liga clip, and the hemolock on graft side. The second Liga clip is basically to make sure that we leave enough margin for transaction, or for the enough margin on the middle hepatic vein side. Segment 8 vein is looped. Clips are applied on both the sides. Because we don't use Pringle maneuver, sometimes some livers tend to bleed because they are very soft livers. Veins are not supported by thick tissues. But some livers behave very nicely, and if you do CUSA, they actually yield. So there was another segment 8 vein, big vein. This was actually the vein which we reconstructed later, the upper vein. So at this point of time, I would also like to thank Dr. Vishal's son Ave. He's just 11 years old, and all the videos are being edited by him. So we must give credit and say thanks to him for doing just a wonderful job. So as we deepen the transaction, this is the last segment 8 vein, which we looped. We actually don't use too much suction from the assistant side, because if we keep on using suction, it keeps on sucking the carbon dioxide and collapsing the abdominal cavity. So we let the blood pool for some time and then suck it later. As much as required is only sucked. So enough space has to be left on the middle hepatic vein side, and it has to be lengthening of veins before clipping. If we don't lengthen the veins, of course, the clips will slip out. The last part of transaction is guided along the middle hepatic vein. And the guide also, the hanging maneuver, the Ryle's tube which we put initially also becomes the guide. Remaining chordate transaction is done with the help of hanging maneuver. So with the assistant pulling the chordate lobe, we just divide the chordate lobe with the Cusa and harmonic device. Once chordate process is divided, the sling is passed. So before doing the last bit of transaction, what we have to do is divide the hilar plate, which is very important part of any donor hepatectomy, because these plates, they do contain small chordate branches. We published an article regarding classification of these chordate branches. So this is what we are trying to loop and isolate, is the hilar plate. So we have to give respect to the hilar plate to avoid any bile leak later. So once hilar plate is looped, we clip it, double clip it on remnant side. You can put 2 Liga clips or 2 hemolocks, 1 hemolock, 1 Liga clip, depending on the space available. Sometimes it becomes difficult. At this point of time, the assistant port helps a lot, because the direction in which the Liga clip goes, I prefer assistant port to be used as the major working port at this point of time. So on other side, we can actually clip it or burn it. Once the hilar plate is handled, at this point of time, the hanging maneuver is done. This Ryle's tube is passed above the right portal vein, taken out. Because complete KY is cleared, lifting of these last part of the liver will not cause any injury to the short hepatic veins. I think there is some stray current here. So there are various Cusa devices available. I think we need to discuss that also. So this is Cusa by Cusa XL, which is Integra, which is quite heavy Cusa. I think I feel a lot of fatigue while handling this Cusa. So another is Soaring Cusa, which was the first Cusa available. And the handheld instrument of the Soaring is very light, which we use after 20% of last transaction is done over the Ryle's tube. Thanks to Master Avia, just 11-year-old. Thank you.
Thank you. That was a wonderful presentation. I think, can I send some of my videos to Avia for editing, please? It was very nicely done. Thank you.
Thank you.
Shall we move on to the next talk? And then
Yes, I think we can take question answers later once we finish with Daniel's talk.
So Professor Daniel Shirky needs no introduction, but everyone knows he's not only a pioneer in laparoscopic liver surgery, but one of the early innovator, as opposed to adopters that we all are, in both laparoscopic liver surgery and in living donor hepatectomy. He obviously traveled the world, initially in Paris, and then went to Weill Cornell and spent about 10 years in New York before returning to become now the surgical director of liver transplantation and HPB surgery at Paul Bruce Hospital. Professor Daniel Shirky, the floor is yours.
Thank you. Hello, everyone. Thank you, Krish, for the kind introduction. I'm going to share my screen now. Can you hear me?
Yes, we can.
Okay. So I believe that's the... So my task today is to talk to you about transection. This is a critical part of the procedure. So I'm going to go around over the general principles, the instruments, the use of Pringle, the hanging, and the survey and guidelines, and brief video of my technique. So basically the principles are here. This is only the graft side, of course, has to be well preserved, but there's so many parts in this operation: Hilar dissection, mobilization, IVC dissection, transection. This is our part today, and we need to provide this kind of graft. The first thing in terms of preparation, I think, is we need dedicated anesthesia, and low fluid anesthesia is very important for the future transection. So basically, I'm just showing this. This is the mobilization, but I'm just showing this to see how flat the cava here is, and we need excellent anesthesiologists to do that. So I'm sure you have that kind of thing. When you don't have low CVP anesthesia, it gets more difficult, much more difficult. The second part for the preparation is ischemic delineation. Of course, we have a temporary clamping of the graft inflow and the mapping of the middle hepatic vein using ultrasound. But the game changer has been ICG delineation, both on the surface of the liver, but also inside the liver, which is very interesting. Another principle is this is a cirrhotic liver, obviously, but any kind of any liver would be like this. This is an old picture that my friend Kaneko gave me from Japan, and I think it really shows you the periphery of the liver, which has no big vessels, and the depth of the liver, which has more vessels, especially hepatic veins. And if you use blind instruments, you may enter those hepatic veins and get into trouble. So this paper was made in preparation to the Morioka conference, consensus conference, saying that probably for peripheral areas of the liver, the energy devices were quick and efficient, but deeper they were blind, and CUSA dissection was recommended. So you need you need instruments, and there's instruments that must be available. They must be well maintained. You must rely on them, and you must master them. These are just a few instruments that I'd just like to comment on. You need excellent scissor. Bipolar is mandatory and paramount. This is the kind of the dissector that we use, the Hilar clamps, the Hilar clips, and the metal clips. Energy device, of course, are necessary. You have the ultrasonic shears. This one is cordless. This one has a cord. Everybody knows them. They're all very good. What you need is the one that you master the best. I've used all of them. For the past few years, I've used Thunderbeat from Olympus, and I really like it. CUSA is really very important for me, and I would be very unhappy not having a CUSA, although you can use some of those instruments to do a crush clamp technique. By the way, CUSA is not presently available for robotic surgery. Linear staplers, you have the bilateral staplers. This one's very good, but it's not, the Echelon Flex is very good because it's powered, but well, I think it's very good. But anyway, what I like also for donor hepatectomy is endo-TA stapler, because they're unilateral. So when you cut a vein, you cut the vein, but you don't have to staple the other side and recut the vein and lose a few very precious millimeters. By the way, they're contemplating to stop manufacturing this device, which is a problem. Also, I'd just like to stress that stapler hepatectomy is not for living donor. You don't want to do the parenchyma with a stapler, or if you want to do a living donor. It has to be a precise and very clean dissection. This is a paper by Kwon reviewing all the published series on living donor hepatectomy, and you see that 8 out of 11 papers were using CUSA. This one was robotic as only the ultrasonic dissector, but most people using pure laparoscopy as using a CUSA. Now let's move to the Pringle. Pringle is a debate. This is an old paper by Makuchi group showing that in open donor hepatectomy, there was no problem using Pringle maneuver. Actually, it reduced the operative time and had no effect on recipient outcomes. This is a prospective randomized trial from Japan, also not from Japan, sorry, from Korea, showing that there's no adverse event. Obviously, there are more ALT in recipients and donors, but in terms of liver function, prothrombin time, bilirubin are the same in both recipients and donors. So more transaminases, but that's all. The Pringle maneuver in lap donor hepatectomy was used in 33% of the reported series, and we'll come back to this. Now the hanging maneuver is very good to finish the transection. We've seen this in the previous videos. We use it only for the end of the transection. Before that, it's not very useful. And you may it may also, if you pull too early in the case, it may create congestion of the graft of the transection line. So be careful with that, and I really recommend to use it only at the end. One thing I want to show you here is how to deal with bleeding, because this was part of the thing. This is a middle hepatic vein. This is here the V8, and you see there's a hole in here in V8. No panic, as we heard before. Just control it, understand the situation. Once you understand the situation, you can very nicely deal with it. This, you will see here that the hole is very visible. We have clamps that are available on our tray, and here is the small hole. This can become a disaster if you don't handle it well, but it's easy to handle when you don't panic, and then you can just go ahead with the transection. I just want to come to some literature. There's been a world survey on donor hepatectomy that was done by Fernando and our group when we prepared for the consensus guideline meeting. And when we contacted, Fernando contacted 34 centers, and we got 32 responses. And you can see that 85%, 84% of the surgeons were using CUSA or equivalent, and energy device was the second one. I guess there was some mix between energy device and crush clamp. I hardly can understand how to use hydrojet during laparoscopy, but I think that some people do. Concerning Pringle, only 12% were using it routinely, but 47% were using it selectively when needed, while 40% never used it. The consensus guidelines on both of these things, on these topics, were the following. For parenchymal transection, the method is left to surgeons' preferences. The use of ultrasonic aspirator is the most commonly used method. However, energy devices or crush clamp are also been reported. It's recommended to avoid blind use of energy devices deeper than the superficial part of the liver. We've seen that. For Pringle maneuver, there's no evidence that the use of Pringle maneuver has detrimental effect on graft or donor, and the Pringle maneuver can be used electively when deemed required, as it may provide a drier surgical field. And the recommendation was that some kind of inflow control should be prepared in the event of necessity. Now, this is a few personal slides. This is the kind of, for a right lobe, I used this with some tilting on the right side that is removed. This is only for liver mobilization at the beginning. Then we can remove this here, and the patient lies flat again. We use 4K widescreen. These are the ports, and we have to understand that CUSA is not very long, so you must have the port close to the patient's, so you can access the upper part of the liver. This is a short video which has been actually fast forwarded. So periphery of the liver is done with the energy device. And the CUSA is used for the deeper portion. If you need, you briefly saw the external Pringle maneuver. This is middle hepatic vein. This is V5, which is clipped and prepared for later reimplantation in the recipient. I like to work in a dry field like that. This is why we need good anesthesia, and if needed, I don't hesitate to use Pringle. Here is we go above the hilar plate here and then pass the tape behind the liver, so we can apply the hanging maneuver for the final steps of, this is a little finger, final steps of the transection. There was no large V8 in this case, only a large V5. The V8s were small. But you can see the middle hepatic vein here, which is nicely preserved. This preserves the cava and gives you the access to the back of the liver. And here is the final view. So in summary, obviously transection is a critical part of the procedure. You need dedicated anesthesia. ICG deinhalation is clearly a game changer. Ultrasonic, the CUSA or equivalent, is the most used device. And I really would be very unhappy to have to do this kind of surgery without it. Intermittent inflow occlusion may be used if needed without deleterious effect. And the hanging maneuver is useful for the final steps. Thank you very much for your attention.
Thank you, Daniel, for a wonderful insight into parenchymal transection, how to manage bleeding. Do we have any questions from the floor? I think there is one that has come, but it's in relation to, I'm sure the panelists can answer that, or the speakers can answer that. The question is there any modification in recipient hepatectomy about pedicle length, right hepatic vein length, etc., when doing liver donor hepatectomy versus open donor hepatectomy? So in other words, whether there is any change in approach for the length of the pedicle.
Well, I don't know, not for me.
No, I thought so.
Not for me either.
I think what would be the one most single tip you would give to people, Daniel, from your vast experience, when you're doing parenchymal transection? What's the one single most thing that you would say to them?
Meticulous.
Yes. Okay. Yeah, I think that's really, yeah.
That's a great answer.
And one of the big discussions that happen often with when you compare the French approach, or shall I say generalized French approach, where you increase the pneumoperitoneum to control bleeding versus not doing that and controlling bleeding the normal way which you described, which is keeping calm, trying to dissect, get the exposure you need, and deal with it as appropriately.
Well, I believe that, well, I never increase the pneumoperitoneum pressure. I may occasionally reduce it. Gas embolus is not a myth; it's a reality. So we have to be careful with that. If you saw the opening that I showed you, there was not much bleeding because the CVP was low. If you increase the pressure, you increase the risk of gas embolus. So this is not the way to go. The way to go is just to be meticulous, and when you have bleeding, just take your time and do it and solve the problem. And if you're in the right plane, by the way, when you do when you do a donor hepatectomy, you're in the plane where there's no, only vessels that you find are hepatic veins. There are no Clisson inflow there. So it's only hepatic veins. So it's always the same way to go. Follow the hepatic vein. The ICG helps, but you just go straight along the right hepatic vein, and all you find is small hepatic veins, and then you have to deal with them. And if I have bleeding, I cannot work in blood. So if I have bleeding, I just Pringle. And Pringle plus pneumoperitoneum at the normal pressure gives you a dry field. And then you can solve the problem. That's my answer to that.
Thank you, Daniel. Vivek, any other questions?
Dr. Cherke, as you had mentioned that like bleeding is something which you are concerned about. What is your take on using argon plasma coagulator, APCs? Do you use routinely? There are some people who have their concerns in using APC in laparoscopic surgery for their own reasons.
So the question is not routinely, but not at all. Zero. I don't use argon coagulator laparoscopically. I don't really use it open very much, maybe in some pontifical transplants for the retroperitoneum. But basically, this is gas under pressure. So you don't want to put gas under pressure in a patient during laparoscopy on a closed environment. If you want to do that, you must open one or two ports so you vent the pressure. But in any case, I don't think this is the way to go, personally.
And I think if I may add one comment, Daniel, to that again, it's dangerous if you've got an open vein, because that's twice as bad.
That's the meaning of high pressure. Yeah, absolutely. There's been death reported using argon beam laparoscopy due to gas embolus.
Which is why in our consensus we said that we shouldn't be using it, isn't it? Yeah. Any other questions, Vivek, or from the
I
floor?
think very nice talk, and from doyen of laparoscopic liver surgery, Professor Cherki.
Thank you.
It was enlightening, and we all look towards you when we started doing our laparoscopic program or donor hepatectomy, and you are the one and who has actually percolated this knowledge down to people like us youngsters. Um, of course, it was a wonderful talk, and we enjoyed your talk. Um, my take on bleeding point, I just want to ask, like in some donor hepatectomies, 1 or 2 times it has happened that clip on the uh, graft side has actually slipped. But we now try to avoid this by lengthening veins and putting the clips properly and do that. In that situation, what would you do?
On the graft side?
Yes, on the graft side.
Well, the first thing is prevention. So you need to dissect enough length so you have a good stump on both sides, and you have that. I don't see any because it's if the inflow is on, then it's going to bleed. So I don't see other way that suturing it. So that means that we need to know how to suture laparoscopically.
Yeah. Okay. Thank you.
In case while doing the transaction, we lose the plane, how to find our way out again?
Don't lose it. I don't know.
Yeah.
Follow the middle vein.
Follow the middle vein. Absolutely. Follow the middle vein. Yeah. I think ICG is a game changer on that subject. Yeah.
Jackie, do you always use intraop ultrasound?
Yeah, we use ultrasound just for in donor, in tumor cases. Of course, we use it, but for donor, it's mainly for the middle hepatic vein. Yeah. Although now that we have ICG, we just clamp, and we have the ischemic delineation. Then we have the ICG. So
we don't have a laparoscopic ultrasound probe. So is it worthwhile to have one, or we can do like we are doing right now?
Pardon me? I'm sorry, I didn't hear that.
We don't, at our center, we don't have a laparoscopic ultrasound probe. So would it be worthwhile to get one, or we can continue with our current practice like we just follow the middle vein one?
Well, I think that's up to you. But I think it's if you're going to do tumor cases, I would really suggest that you.
Because it's very difficult to convince the hospital to spend money.
Yeah. So have them get it.
I think,
get it to the hospital. Yeah.
I think it's £60,000 worth of investment, I think.
Yeah. So it's a good investment. You won't regret it.
No.
Thank you.
I think so. Dr. Rajnikant has a question. So over to Rajnikant.
Very nice talks and videos. And nice to you, Mr. Menon. Great to see you. And one, we have talked about mainly right donor transection. I have a small question about left and left lateral transection. Any tips and techniques? Mainly when left lobe, we are separating from the caudate lobe. Lot of bleeding, and sometimes you miss the plane. Is there a trick or how techniques?
Yeah, I agree with you that the passage of the Arrhenius fissure between segment 1 and the left lateral lobe is an issue. So what I do is so you have to dissect the left portal vein, left portal vein, left hepatic artery. Once you've divided the bile, you can divide the bile duct or not, but basically what you need to do is lift the pedicle, and then you can pass behind, and then you see the Arrhenius fissure. And here you can divide segment 1 pedicles one by one, or you can also occasionally staple if you have space here. But basically, this is an issue. Concerning the transection in full left lobe, it's about the same as the other one. We use left liver with or without middle hepatic vein, depending on the recipient side. And for left lateral, you need to divide the segment 4 pedicles along the way as well. So it's different operations. But at the end of the day, you dissect the hilum, then you cut the liver, and you get to the hepatic vein. And I think we're going to hear the bile duct is a critical time that Fernando is going to cover now, and he's a real expert on that.
Okay,
thank you.
It was an excellent discussion, and it was pleasure to have Professor Cherki, Professor Menon, and Dr. Shaleen. I think so. From want of time, let us move on to the next session.
Thank you very much.
Thank you very much.
Dr. Ashish.
Meticulous is the word, I think. Yes.
Thank you.
Thank you.
The next session is an industry-sponsored session by Ethicon. It's going to be taken by Ms. Minu Dhan, who's a senior manager biosurgery, and she's going to talk about the role of adjunctive hemostats and bleeding management in liver transplant.
If the organizers can confirm, they can see the screen.
Sure, we can see you, Minu.
Thank you. Okay, great. Thank you, sir. Very good evening, respected faculty and the delegates. First and foremost, sir, can you see me? I can't see myself on the screen.
Ma'am, please start your video. Yeah.
Okay, thank you so much. So, very good evening to everyone. First and foremost, a sincere thank you to all the organizers at AILBS for this opportunity. My name is Minu Dhan, and I'm part of Ethicon Johnson Johnson Medical. To set the context, in next 10 minutes, we'll try to showcase adjunctive hemostat solutions we have for managing surgical bleeding challenges when primary methods or conventional methods like sutures, clips, or electrocautery do not either give desired results or cannot be used because of the criticality of the tissue. The Ethicon portfolio of adjunctive hemostats, it's an area which has been dedicated to assist in surgeries by focusing on array of technologies. And when I say an array of technologies, because in the next couple of minutes, I would be talking about just 7 solutions, but our worldwide and global team is working on many more solutions, especially in the fibrin sealant space for surgical bleeding management, and these would be available in next couple of years. Our esteemed surgeons would agree that the patient which comes today suffers from growing number of comorbidities such as uncontrolled diabetes, such as obesity, cancer, all of which can increase surgical bleeding risk and can also negatively affect body's natural clotting process. And at the same time, what we've witnessed, there's a number of older patients which are undergoing surgery and are leading to more extensive and more complex procedures. So although managing bleeding during surgery is a basic element in any procedure, patient outcomes, hospital resources, or cost can all be adversely affected by surgical bleeding events. In fact, we were looking at a certain data points clinically in open procedures that have a high risk of bleeding. There's a 32 to 68% of such cases which can escalate to a major bleeding event. And this data was found across different surgical fields, whether it's cholecystectomy, cystectomy, even in cardiac space. Now, what happens is these major events and the related complications are associated with overall increase in the hospital resource utilization. And these days, the management is always talking about the resources or to reduce the resources which get utilized. So as numerous studies which have demonstrated, when compared with conventional methods alone, use of adjunctive hemostats help reduce hospital resource utilization. And as a esteemed surgeon would have likely witnessed, today there's a growing hemostatic market. There is a growing hemostatic products option as well to choose from. And these sheer number of choices, along with no standardization in terms of which hemostat product to be used in what kind of a site and situation, has majorly led to either a suboptimal use of a hemostatic solution or a certain dissatisfaction in the minds of the surgeon. So what we at Ethicon did, we did a very large scale quantitative study, and this study was spread across 450 surgeons, 11 specialties, looking at 8,000 bleeding situations. We categorized bleeding situations into the top these 5 categories. At Ethicon, we offer optimal product solutions for different such bleeding situations. These are the ones which are mentioned below, and I'll take a minute to talk about them. This is a Surgicel family of topical absorbable hemostat, and I'm sure in your esteemed career, you would have used either one of them by now. So Surgicel is the most trusted brand. It has a 60 years of proven safety and efficacy data. We have 5 unique solutions in Surgicel. The one in the middle is Surgicel powder. It's a powdered ORC. It's yet to be launched in the country. But this is meant for broad surface continuous ooze. So especially we would recommend this for continuous oozing situation during hepatic surgeries. A little bit more. So Surgicel Original, I know this is one of the favorite products of our esteemed surgeons. It was launched in 1960. It's almost 60 years. This is a product which revolutionized the whole space. It's known for its flexibility and reliability. It has a shear weave. You can actually see through the same and can be used with the electrocautery. Fibrilla, it's known for its versatility, adherence, and conformability. It can be peeled into almost 7 to 8 layers. If you compare this with Surgicel Original, this has 39% faster time to hemostasis. And we especially recommend usage of same around critical areas. It's a very, very light weight hemostat. Surgicel unit, it's 3 times denser than Surgicel Original, known for excellent strength and coverage. You can suture through it. We recommend this to be used around solid organs, and this has 36% faster time to hemostasis than Surgicel Original. And our latest offering in the ORC space is this is known for its adaptability and conformability. This is the fastest one. When compared to Surgicel Original, it is 43% faster. Like Fibrilla, 1 layer of snow is more effective than 4 layers of Surgicel Original, and it's an ideal solution for minimally invasive surgeries. These are the various options variants of ORC which I just spoke about with Surgicel powder to be launched soon. In the flowable space, we have Surgiflow, which is a gelatin-based matrix. This is recommended for difficult to access places, and we especially recommend this around wet areas, especially in the ENT space and where there's a pool of blood. This is one of our most advanced technologies. We call it a clot in a bottle. It's made of human fibrinogen and human thrombin, and we recommend this for potential patient with either high risk or the surgeries where there's a potential for rebleeding risk. And this is the last slide. This is actually, it's a reference tree for us, and this is built across different specialities. When we as Ethicon representatives go and recommend a solution, we use this. So there are different bleeding sites on top you can see. So if you can see and access a bleeding site, continuous ooze, we recommend to use ORC. If there are multiple bleeders, we recommend to use a fibrilla. If it's a minimally invasive, we recommend to use snow. If it's difficult to access, we recommend Surgiflow. And if a patient is a high-risk patient and there's a certain pre-exposure surgery, we recommend to use Evisil. That's all from my side, and thank you so much for this opportunity. Thank you, everyone, and have a great evening. Thank you.
I'm stop sharing, please.
Do we have any questions from the audience? Hello? Minu, can you hear me?
Yes, sir. Yes, sir.
Minu, is there any advantage of or recommendation for using the fibrillar or Surgicel over the other hemostatic agents?
Right, so thank you. Thank you, so for that question. So as I said, our recommendations are based on the site and situation, what kind of bleeding intensity it has. So for example, if there are multiple oozers at the surgical site, we recommend usage of fibrilla because it can be peeled off and could be put across multiple oozers, which cannot be done with Surgicel original and snow unless you cut it and then put it. So advantages and other advantage, as I just mentioned, fibrilla has a 39% faster time to hemostasis than Surgicel original, and one layer of fibrilla is more effective than 4 layers of Surgicel original. So there's a premium, but if you look at the overall advantage which comes with these advanced technologies, these are much more than compared with legacy products. I hope, sir, I answered your question.
Yeah, you did. But how can we make these products more cost effective or maybe more economical from that perspective?
Right, sir.
I think that was one of the reason like the surgeons tend to avoid. Definitely, if surgery needs it, we all use it. But if there's one of the reason that all the surgeons kind of try to avoid using all these products or maybe the other glues and everything any other even the competitors have. What's your take on that?
Sir, I think it's a great question, and it's very, very relevant, especially when we look at Indian population and their pain capacity, sir. So when I was going through my talk, I think at all places I mentioned adjunctive hemostats, and it's no solution to your conventional or primary methods. All of this has a role. So your adjunctive hemostats have a role play when conventional methods either can't be used because of the criticality of the tissue, or the conventional methods have not given you the desired result. So, sir, it's only need basis, and we do not recommend usage of the same in all the bleeding situation. In terms of making them cost effective, I think it's a very, very difficult question for me to answer. So every good technology and at a quality comes with a certain cost and a premium, sir. Thank you so much.
Got it. Thank you. Thank you, Minu, for joining us and for that wonderful presentation. Thank you so much.
Thank you so much, sir.
Now we can move to the next session on division of bile duct and hilar plate. And I invite Dr. Vishal Chaurasia in our team, and he's going to moderate this session.
Thank you, Dr. Ashish. For the session on division of bile ducts and hilar plate, I would like to invite the chairpersons, Dr. V. Pamecha and Dr. Rajshekhar Paramula. Dr. Pamecha is the professor and head liver transplant and hepatobiliary pancreatic surgery at Institute of Liver and Biliary Sciences, New Delhi. And Dr. Rajshekar Parmula is Consultant, Department of Liver Transplant at VPS Lakeshore Hospital, Kochi, India. Dr. Pamecha,
Can you?
can you hear, sir?
Hi. Hi. Thank you very much. Thanks.
Yeah.
Thanks, Vivek, for having us there. So it's an important topic. Next topic is an important topic about how to divide bile ducts. I think biliary complications are very much related to how you handle bile ducts actually during the transection and obviously how you're going to join them again. So how you get them good is the most important thing. So for that, I invite Professor Fernando Rotella for giving enlightening us about how to divide bile ducts and Hilar plate in live liver donors.
Excuse me, Dr. Pamecha, I think we can have our AILBS video followed by which we can have Dr. Fernando's talk.
Oh, okay. Okay.
So I think we can move on to AILBS video for the bile duct and Hilar plate division.
Okay. Sorry, I didn't realize that. Okay.
No issues. So this case had type 1 biliary anatomy with a single right hepatic duct. So as I initially told that during the phase of porta dissection, we delineate the junction between the division of right and left hepatic duct. Sometimes it's very important to do it at this stage because later on when we come, there's a lot of edema. So our preference is to lift the hilar plate and go to the junction of right and left. Just make a space. We don't try to loop it at this point of time. The dry field with the help of gauze really helps during this dissection. Once we have delineated or marked the midpoint of right and left duct, after that we do is parenchymal transection. After parenchymal transection, we come back to the bile duct. The hilar plate, which is a thick structure overlying the bile duct, junction of right and left hepatic duct, is identified. So we define it as we have described it as a Delhi technique in which we incise the hilar plate. Divide the hilar plate. It's important sometimes to divide the thick hilar plate because then ICG becomes very easy. The ducts underlying can be easily delineated with the help of ICG. And with a single duct, if we do it properly, this Delhi technique, then without burning or without using energy device, we can actually loop the duct. So this was a real technique where we didn't use any energy device to loop the right hepatic duct. So it can be easily looped without using ICG also sometimes. But if there is any issue, then of course we should use ICG. After that, we can actually confirm that the right hepatic duct is looped. You can see beautifully that left duct, right duct, and the common hepatic duct. There's a good space to put up a clip. Our preference is to put up a one hemolog clip on this side. And under ICG, we always put clips under ICG. Leave enough stump on the left hepatic duct side. And second clip is just a metal clip just to make sure that when we divide the right hepatic duct, enough margin is left on the left side. And we freely divide the right hepatic duct, and we usually accompany a hilar branch of artery, small artery, which are kind of crossovers between right and left side,
which can be just picked up and clipped to stop the bleeding. And sometimes if we can just put a gauze piece and come after some time and the bleeding stops on its own. The point here is not to panic with this bleed, because this is as usual, we see it in all the cases. Once bile duct is divided, we can see the portal vein beneath with a loop. We divide the areolar tissue. The next step is of course to handle the hilar plate, which contains chordate branches of the bile duct. It can contain chordate branch crossovers from one side to another side, and hilar plate has to be looped and clipped or stapled depending on personal choice carefully. So to completely loop this hilar plate, what we do is clear the areolar tissue superior to the portal vein. Once that tissue is cleared, and we widen the space. You can see a small branch of the portal vein, chordate branch of the portal vein at the junction. Make a space from above. After that, we divide the chordate lobe, chordate process. Once the chordate process is divided properly, we pass a right angled forceps from below the portal structures above and completely loop the hilar plate, which is separated along with the posterior portal sheath. Now what remains in this loop is just a hilar plate. We clip it, and other side we can actually clip it or divide it with the energy device. This is a small portal branch, as I mentioned, which we can actually burn or seal with the energy device. So later on the graft side, we have to suture the hilar plate, and on the remnant side, of course, there are some special scenarios like 3A duct, or so in this case there were two ducts. It was a 3A anatomy where right posterior duct was draining into left hepatic duct. So in difficult anatomies, sometimes what we do is intraoperative cholangiogram, just to make sure that we don't damage the left or remnant duct. So this was the cholangiogram. There were two ducts draining. They were parallel. The distance between these two ducts was not too much. So after looping and doing cholangiogram, again the same method of clipping and division of the duct. First duct, and here you go with the second duct. You can clearly see two ducts, parallel ducts in the same sheath. There are various ways we can handle these ducts depending on the anatomy of the duct. So in this case, there was a same anatomy, but ducts were very far away from each other. So this was the first duct which we ligated. The same technique of ligation and division. The first duct was isolated separately because they were far away. And the second duct was, if they're far away, we loop along with the hilar plate. And they are clipped en masse. So the hilar plate along with the second duct is looped, clipped, and divided, leaving enough margin on the remnant side. So this is the second duct. So for till now, we don't have any biliary contraindications or case selection criteria. We accept all the cases. Although you need meticulous dissection, intraoperative cholangiogram, and everything. After division of the bile duct, we ligate the hepatic artery. For removal, we usually use 2 clips, hemolocks. Some centers or some surgeons would also use a third clip, which is a metal clip. As the artery is taken down, the liver is hanging with the help of portal vein. We use TA single-sided stapler at this point of time to divide the portal vein or just clamp the portal vein, leaving enough margin on left side. And we leave it as such to divide it later. After that, we divert our attention to the right hepatic vein. Which we divide by echelon flex. So this case I was mentioning that there was a injury to the right hepatic vein, which we stopped by just putting 2 clips. And because it was in the end, we thought of not suturing it, just removing the clips and firing the stapler. This was far on the side of graft, so it didn't bother us. There goes, we fired it. Last bit, sometimes the vein is long and last bit you might have to clip or divide depending on the case. this bleeding is from that same side, graft side. You can see clean cava. After that, now it's our protocol to divide the portal vein in the end and make the bleed out in the cavity. We remove the tongs and tighten the thread and pull the liver out. The warm ischemia time in this case was close to 4 to 5 minutes. Usually our warm ischemia time now is under 3 minutes. This is suprapubic incision. I think this is the unedited video of graft retrieval. Drops out. After that, we check for hemostasis. Close it. Thank you so much. Professor Pamecha.
Yeah. Vivek, fantastic. Well done. Very nice video, actually. Really liked it. Enjoyed it a lot, actually. So, shall we have the discussion after the next talk? Or
Yes, I think so. Let's proceed with the talk and then we can have discussion.
Okay. So, the next talk is going to be from Professor Fernando Rotelar. He is from Spain. He's head of General and Digestive Surgery Department of Clinical University de Navarra, Spain. So he's going to talk about the intraoperative cholangiogram, especially about the ICG, and obviously the division of the bile duct as well. So over to Professor Fernando.
Hello. I'm going to share my screen.
Yeah, we can see you.
You can see it?
Yeah, we can see you. We can see your slides as well.
All right. Oh, great. So hello, everyone. Well, congratulations for this wonderful meeting and also for your experience. And my talk is about ICG cholangiography. Well, we have seen along the day how ICG has emerged as a very useful technology in liver surgery in many applications, as we have seen in the previous videos, but also on bile duct visualization. We can use it in simple procedures like gallbladder removal, but also in complex ones. And I'm going to show you a beautiful demonstration of this in a right anterior sectorectomy. We are doing here a Glisonian approach of the right anterior pedicle. We clamp the pedicle, inject the ICG, and now we proceed along the transection plane as we have seen before. We have now concluded the medial transection plane, and now it is time to divide the right anterior pedicle. And before that, we must always bear in mind that we may have this kind of anatomy. And if we put the stapler here, we may damage this right posterior duct. And this is exactly what we found in this case. And thanks to the ICG, we could very clearly identify this right posterior duct crossing behind the right anterior pedicle. So we could take our time to enlarge a little bit the length of this pedicle in order to insert safely the stapler and in real time to check the integrity of the right posterior duct. And well, this is the final aspect, the right posterior duct crossing behind the right anterior and the surgical field. So it's really a very useful tool, but here we're here to talk about pure laparoscopic donor hepatectomy. And the million-dollar question here is, which is the role of ICG cholangiography in minimally invasive donor hepatectomy? In September 2019, Dr. Cherki has talked about this. We had a consensus conference on minimally invasive donor hepatectomy organized by Dr. Cherki and Professor Su. And a group of experts worked for months in advance and then gathered together in Seoul to discuss 15 clinical queries on living minimal invasive approach on donor hepatectomy. And I was entrusted to talk about best method for bile duct identification. So this was the question, which is the best method for bile duct identification and closure? And well, in preparation for this meeting, we performed this world survey on the adoption and spread of minimal invasive donor hepatectomy around the world. We gathered a very important number of cases, the geographical distribution, among them our hosts today from Fort Fortis Hospital. And apart from these numbers, we also asked for technical aspects. And regarding bile duct identification, we found that 1/3 of the respondents used only ICG, while 2/3 used cholangiography with or without ICG. 1/3 ICG, 2/3 cholangiogram. We were looking for the evidence, so we did a very thorough literature search and under strict criteria, and we found that there are no comparative series or evidence. The level of evidence is relatively low. Intraoperative cholangiography was mentioned in 41 papers, while ICG in 12. Cholangiography, well, it was reported in the first, two of the first papers that reported adult minimal invasive donor hepatectomy for adult recipients. The paper from Ghent, from Roberto Troisi on left hepatectomy, and the first report of pure laparoscopic right hepatectomy in a living donor by Olivier Soubran. And here we have these beautiful cholangiograms. Soon after, we described the real-time cholangiography. What we do is to put the plumb apron on, and we bring the C-arm into the surgical field, and we can perform real-time cholangiograms. This is a thing that in open surgery you cannot do because this occupies a room, some space in the surgical field. You cannot do in real time as we do here. Like an interventional radiology, we can divide in real time. Here we have this anatomy with two ducts. We open the liver. We minimize dissection on the hilar plate, and we put under direct vision exactly the scissors where we want to divide the biliary duct. So we have divided here the first duct, and now here the second duct under direct vision. Then, well, we close the ducts with 6/0 monofilament as we would do in open surgery, and we can take a final check to rule out stenosis or leaks. And well, this is basically our technique. We divide sharply the hilar plate in block, trying to identify the precise place to divide. From our second case, we included ICG, and we use both methods, but still we keep using cholangiogram because we feel that the the most precise picture is only obtained by cholangiogram with the C-arm placed during the division, and we have found cases like this. These two ducts, the posterior duct receives is not very clearly seen here, but after division of the first one, we could see how the posterior duct receives a branch from the left liver and a branch from the right liver, and we could divide, preserving exactly preserving the integrity of the left hemiliver biliary duct, something that we only can do with this cholangiogram. Regarding ICG, well, there were 12 papers in the literature, 6 of them from the Seoul National University Hospital. Of course, this may result in bias, but at the same time, this is a very, very important experience because this is a huge experience and they have really studied in depth this technique and their results. They applied, they correlate the ICG with the preoperative MRCP, and they have applied the ICG as the only method in any possible anatomical variation of the biliary anatomy. And this is how they do it. This is the image that they obtain, very beautiful and very clear images of the bile ducts. We can see here. Pay attention to these 2 clips because we will come later to talk about this. And after dividing, they do clip and divide rather than divide and suture. And now they go to divide the second duct. Well, which are the outcomes of this experience? As I say, the most numerous in literature. Well, in the preliminary experience, no biliary complications in the donors, and in the updated experience with an important number of cases, only 1.7% of biliary complications in the recipient. So to put this number in context, it seems low, but how low it is, we can compare with the benchmark study by Clavian performing a large cohort of open living donors, where the biliary complications in the donor was 3%. So this 1.7% is very, very low. So this the use of ICG is clearly safe for the donor. At that time, at the time of the conference, we didn't have data on the recipients. So we redacted the recommendation like this: intraoperative cholangiogram and real-time ICG are the available methods to identify the best location of bile duct division. Low level of evidence, but a strong form of recommendation. Well, soon after the conference, some more evidence arrived on the outcome on the recipient using the ICG method. And I'm going to present what I consider the 2 most important. First one by Dr. Brerin in right hepatectomy, robotic right hepatectomy. And well, what they do is very interesting. They do a tiny opening of the duct and they explore with a probe, and then they continue the division of the duct. And with this technique, well, the outcomes on the donor are very low, and the complication very good. And on the recipient, there are very low complications too. But this is an important number, but it's still preliminary, and these are short-term outcomes. And the second experience is again from the Seoul National University Hospital. And now they focus on the recipient outcomes following this policy. And the first, well, there are 2 very important findings. The first one is that there are unexpected increase on bile duct openings in the laparoscopic group. Well, the matching is perfect. It's a propensity score analysis with an important cohort of laparoscopic and open. And there is a dramatic increase on the number of bile duct openings in laparoscopy. And most importantly, there are significant more early biliary complications on the recipient, and even highly significant more late biliary complications that reach up to almost 40% of the recipients of the pure laparoscopic right hepatectomy. Leakage and above all biliary extractions in the long term. So this is a word of caution. This is a very important experience, and we must keep this in mind. Which are the reasons that they justify or they discuss in the discussion? Well, the multiple ducts probably due to this method of double clipping and divide, because double clipping occupies some space that may result in multiple bile ducts. And which is more important, the biliary complications. Two warnings. The first one is the use of energy sealing devices used in laparoscopy may result in injury of the bile ducts. And also a warning on the use of ICG, because really to obtain these good images, you need to clear off, to expose more the biliary or the biliary bifurcation, the hilar plate. And this additional dissection can result in the vascularization of the bile ducts, causing ischemic injury. So I wouldn't blame on the technology, but this is really a word of caution that we must keep in mind. So to conclude, ICG technology is really a very useful tool, particularly good for biliary duct visualization. But when we go to the biliary duct, well, this is a crucial step with implications for both donor and recipient. So we must use wisely the technology that we have. So we must do a rational use of our tools. Probably ICG could be the only method in most of the left hepatectomies, but when coming to the right, as we have seen in the presentation by the AILBS group, in right hepatectomy, probably we may choose in a case-by-case basis and strongly consider the combination in case of doubts. So I consider that this is still open for debate. Evidence is still low, and well, I think that we need still further research to clearly identify the technology and the best technique to divide bile duct and hilar plate in minimal invasive donor hepatectomy. Thank you very much for your attention.
Thank you very much, Professor Rotella. That was fantastic, actually. I think you put on it very well that the issues about all the donor side, maybe it is getting safer, but whether we can translate it onto the recipient side and how technology, limitations of the technology which are available. So now we are open for questions. We haven't received any questions, but Professor Fernando, are there any means in terms of translating onto the recipient side? Do we have any data on this? On means in terms of transaction from laparoscopic and robotic bile duct transaction, translating into increased recipient complication rate, or do we have that data to?
Well, the most important evidence are the two papers that I have presented, and they are controversial. So this is why I wouldn't blame on ICG. So it's not technology, probably it's technique. And we have to learn how to use this new technology. The paper by the Seoul National Hospital is a very honest paper, and they study in depth this the use of this technology that seemed very safe, and it was, it is for the donor. For the donor, it's absolutely safe. But when we go to the recipient, we may have this long-term complication if we expose the hilar plate. Well, I remember when I began doing living donor open. I went to learn with Professor Amadeo Marcos 20 years ago. And it was like the first commandment was avoid dissection on the hilar plate. because the major concern was the biliary complications that are the Achilles heel of this the right lobe. So avoid dissection on the hilar plate, and this is why we prefer to sharply divide the hilar plate and perform this cholangiogram. ICG technology is tempting, and occasionally we have very, very beautiful images. I think in a single dot, if we clearly see the confluence, well, as we have seen in the previous presentation, well, you can, obviously, there is no need to do a cholangiogram. But in case that there are some doubt, maybe it's better to use everything we have in our reach to ensure safety for both donor and recipients. We have to consider that biliary complication in the recipient is terrible. It causes a lot of suffering for the recipient, readmissions, percutaneous procedure, economical burden, and even occasionally a retransplant. So everything that we can do to ensure both donor and recipient must be done.
I completely agree with all your statement. Actually, fantastically put in terms of how we need to be careful. So, Vivek, can I ask you as well? You shown very good videos. So normally in open, what we do is we complete the whole transaction, and then basically what we leave is the hilar plate with the ducts, right?
Yeah.
And then that's what we do. But looking at your video, it was more of slinging the bile ducts separately and then dividing them, and then dividing the hilar plate later on. That's the sequence which was followed.
Yes, that's the sequence we follow in open also.
Okay, so you try and sling the duct separately and then divide the hilar plate.
So, Pamecha, we have recently sent a video on AHPBA. We are now describing a technique of bile duct division called as Delhi technique, in which we loop the duct. This is Delhi means extra hepatic looping of the duct by cutting the hilar plate sharply. So as Roteller perfectly pointed out, that we should not use energy sources near the hilar plate. So what we do is, initially in my videos, which you have seen, we define just the junction mentally between right and left hepatic duct. And once we complete the transaction till that point, we divide the hilar plate sharply with the scissors at that point of time. And then it becomes easy, because once hilar plate is off, the vision of duct under ICG is very clear, because ICG penetrates only 5 to 10 millimeters that he is mentioned. So once we are done with that, then we loop the duct from behind, and it becomes very easy to loop the duct in such a way, because once we are above the confluence and divided the hilar plate, then it becomes very easy. So till now, in 75 donors, 75 recipients, because the actual point is what happens to recipient in these ducts. I think Roteller pointed out nicely with that paper. So till now, we haven't had any bile leak till now, but our experience is small, and we hope that this continues. And long term, we will look into the biliary strictures part of it, and let's see what happens. But till now, we have been quite happy with our own technique of dividing the bile duct. And later on, after bile duct is divided, we loop the hilar plate en masse, and then complete the parenchymal transaction, which is 20% over the cava, over the sling.
Okay, so I think that's an interesting way of doing things. So let's see what will be the long-term results of this. Because so any other questions we have?
Fernando, Ashish this side. Excellent talk. Quick question. What's your take on energy devising sealing the bile ducts? Like suppose we encounter some small caudate ducts and got is energy device able to any thunderbeat or harmonic to seal these bile ducts?
Well, that's a good question. Really, in not in living donor, but also in regular laparoscopic liver surgery, we seal these caudate biliary branches with ligasure, and they are perfectly sealed, and we haven't had any leakage from them. So it seems safe. Yes, curious, but it seems safe.
Thank you.
Any other question? Very nice talk, Fernando. We really enjoyed your talk. It was apt on literature and the points we should look into while doing laparoscopic donor hepatectomy. It was fantastic talk. Thank you so much for being part of our conference.
Thank you very much for inviting me.
Now we can move to the next session. It's an industry-sponsored session from Ethicon. The speaker is Dr. Shastri, who is going to speak on use of powered vascular stapler in laparoscopic donor hepatectomy. He's a senior director, cardiothoracic surgeon by itself of medical and senior director at Medical Clinical Affairs in Johnson & Johnson Medical Services. Over to Dr. Shastri.
Thank you very much, sir. Good evening to everybody. I hope you can see my screen.
Sure.
Can you see my screen? I'm sure it appears to be visible. So my name is Anand Shastri. I work for Johnson & Johnson as the medical director. The powered vascular stapler is one of the first devices, and there are a few others, that was designed in Asia. And the need for such a device in complex operations, which include thoracic operations as well as liver and kidney operations, was found because it had precise access because of its narrower profile, enhanced visibility because of its increased articulation, and much more improved stability because of its powered division and powered application of staples. So the entire device has been changed from the regular stapling device that you know. Bleeding does matter. Major organ vessels are fragile. They're prone to bleeding. We use extreme caution during vessel dissection and exclusion, but bleeding is still a major barrier. And my colleague Meenu Dhand did mention that there is a high incidence of problems that occur in operations that are prone to bleeding because of the very nature of the operation. You can have lots of problems associated with staplers, as I've enlisted 4 of them on the screen for you. It can occur because of many reasons, and all these reasons can give rise to catastrophic bleeding, which can either lead to conversion of an open minimal access operation to an open operation, or it can lead to a serious morbidity or indeed even a fatality on the operating table. The tissue-specific design of the powered vascular stapler is extremely important. It's different in the way it actually closes as regards the staple as compared to all other staplers, which close in a V shape. This closes in a flat shape, which is more like a hemostatic clip. And it has a range of tissue thickness, which extends from 0.75 to 1.5 millimeters of tissue thickness, which means that it can actually cover a wide range of vascular structures that involve very thick structures like the renal artery and very, very thin and fragile structures like the pulmonary artery and vein. Most complex operations, including the ones you're discussing today, which are liver operations, have tight space which limit the accessibility to the site. Most staplers that you have are about 1.2 centimeters in width across, and this one is just 7 millimeters, which actually allows you to be able to give a wider range, to be able to visualize the vessel that is being divided. In addition to that, particularly in thoracic surgery, which I do, lymph nodes and tumors which are sitting on the major vessels can actually limit the length of the vessel that is available for dissection. Most importantly, if you do divide a vessel at an angle as compared to 90 degrees, you increase the cross-sectional area, which lowers the burst pressure, which basically means you're converting a 5 millimeter vessel to a 7 millimeter vessel. Having an increased articulation angle, having a narrower curved tip, and having powered firing actually give you the advantages in all those tight spaces that you have. There's plenty of evidence in the thoracic space. Basically, this was designed for thoracic surgery, but now the use has been extended to all others. In thoracic surgery, across Japan, Korea, where I was based for about 4.5 years, it has given incredibly good outcome results from an economic as well as a clinical outcome perspective. And I've shared a few on the screen with you, but this is true for many other organ systems as well. There is a strong surgeon value, there's a strong hospital value, and there's a strong patient value. And the reason for that is vessels are much like a balloon. A puncture in a balloon which is not inflated is very different from a puncture, the same puncture which when the balloon is stretched or expanded. And the same thing applies to blood vessels. Though you may have different ranges of thickness of the vessel wall, stretching a blood vessel can actually give rise to division, accidental division of the blood vessel, just as the knife begins to touch it. Some examples on a latex tube that I've demonstrated is when you're applying a vascular stapler on a vessel, you can actually give the vessel a little bit of stretch or tension, which should be minimized. And the method of application of a vascular stapler is what I'm demonstrating now. While placing the vascular stapler, you may need to actually stretch the vessel to be able to see both sides of the stapler effectively. Following that, it is important that you use the articulation as well as the fulcrum of your minimal access port to be able to reduce the tension before you actually proceed to divide it. Because if you do reduce the tension, then the chances that you may accidentally tear open the whole vessel, like with the touch of a knife on a balloon that is massively inflated, will be very, very low. These are some videos from thoracic operations that show the application of the vascular stapler. As you can see, the vessel is extremely, extremely stretched when you apply the stapler. Then depressing the handle or increasing the articulation allows me to divide the vessel quite effectively. A second video also demonstrates the same. The video will play shortly. You can see the white can actually make it very white. And this is dangerous. Whether you're using a vascular stapler like this one, which is designed for vascular tissue only, it's got 2 rows of staples on either side. So it's difficult to use it for tissue that's not vascular tissue. With that, I've completed my 10 minutes. Thank you very much for a patient listening. It's a wonderful conference I've been listening on since quite a long time. Congratulations, many congratulations to the organizers. Thank you.
Thank you so much. Any questions from the audience? Right?
Well, Anand, I think, can I ask a question?
Yes, sir, please.
Yeah. Your vascular stapler of Ethicon, I routinely use it. I think it's a wonderful thing on vessels when judiciously used. So I was talking to one of your colleagues. I was wondering that is Ethicon in process of making thinner than 7mm staplers? Because sometimes we have to use it in spaces which are even thinner for maybe Hilar plate division or small vessel division. Maybe a double row can also do, or something like that. Means there were some companies in US which came up with a micro cutters. Later on it was discontinued. Is Ethicon in look for searching for such kind of staplers?
Thank you, sir, for that question. I agree with you. Smaller staplers and micro staplers are better. Ethicon is certainly looking towards it, but at the minute, the technological limitations of being able to provide 2 rows of staples on either side, as well as a powered knife which divides the tissue, has sort of limited us to the end effector of about 7mm. Going below 7mm, I'm not sure if it will happen over the next few years, but it is a constant quest for us to be able to make the most minimally invasive and least traumatic stapling device.
How about single-sided staplers without cutters?
So we do have them, and they're used in renal transplantology to give you a length of vessel.
Are these vascular staplers?
Yes, sir.
Laparoscopic, powered or not powered?
No, not powered.
Laparoscope.
Yeah.
So I was looking for them. I don't think.
Well, yeah, to be specific, they're not available in India, but they are available in many other countries. Now, commercial reasons for launching a device in India include regulatory approvals, the necessity to do clinical trials or real world evidence on staplers, and of course, the commercial benefit in volume of procedures that is to be done, that is looked at by all commercial organizations. So I'm not a commercial person. But at the minute, we have them in Korea and Japan, but we don't have them in India.
Okay. Okay.
Thank you, Anand. So I think we should move on to the next session, which is minimally invasive donor hepatectomy 2021 and future. And to carry on the session, I would like to request Dr. Vivek to take over and invite the chairpersons.
So I would like to invite chairpersons for this session. Professor A.S. Soin, who needs no introduction. He is chairman and director of liver transplant and HPP surgery at Medanta, the Medicity. And I would also like to invite Professor Sudhindran, who also needs no introduction. And he is professor and head of liver transplant and GI surgery at Amrita Institute in southern part of India. Sir, you are welcome on the chair. Sir, Dr. Swain.
Hi, Vivek. I wasn't sure which side was scanning on. Hello, everyone.
Hi, sir.
Hi, Olivier. Good to see you.
Hello. Hello. Good to see you too.
Dr. Swain, can you invite Dr. Olivier Subrin for his talk?
Hello.
Dr. Swain, can you invite Dr. Olivier Subrin for his talk? Are you able to hear me, sir? Okay, I will invite. So I did take this opportunity to invite the pioneers of laparoscopic liver surgery and living donor laparoscopic donor hepatectomy, Professor Olivier Subrin, who doesn't need any introduction. And he's published extensively in all the high index journal, and his articles are kind of guiding light to people who want to start laparoscopic donor hepatectomy or laparoscopic surgery. Professor Subrin, stage is all yours.
Thank you very much, Mr. Chairman, and thank you again for your invitation. So today I will try to show you my slides, if I can. Where is my slides? Can you see my slides?
Yes.
Okay, good. So to try to stick on the time schedule, I will show you some data. No more videos. We saw very nice operations in the previous sessions, and I will try to show you some data, and maybe in the second part of my talk, a few personal opinions about the situation of laparoscopic donor hepatectomy. This slide shows you the brief history of live donor liver transplantation, and you can see that it's a recent history, with the first LDLT performed in 1989 by Russell Strong and Raya in Brazil. And you can see that Daniel Cherki and I, we performed the first pure laparoscopic left lateral sectionectomy in 2001. And it took a few years to switch to the right side, because it was more complex, of course, procedure. And in the same year, we, Fernando Rotelar and I, we published our own cases in the very same issue of AMG Transplant in 2013. So you see it's a rather short history for pure laparoscopic donor hepatectomy. I'm not sure it's working. Okay. On this slide, I wanted to list what could be the specific risk of laparoscopy for living donors. And regarding the donor himself, I think that the risk of hemorrhage and transfusion, especially the risk of bleeding coming from the hepatic vein, could represent something related to the specific use of laparoscopy. I want to say also that we may fear a secondary bleeding because of an unsafe vessel occlusion comparing to open surgery, and a potential increased risk of biliary complications. And I will get back on this specific point a bit later. Regarding the graft side, we may have some shorter vessels length and vessels and bile duct, of course, and a longer warm ischemia time that may represent also a risk, especially for the bile ducts. So I was speaking of the beginning, and these two cases we published in the Lancet, and later on we showed that the comparison with open cases was favorable to laparoscopy with less complication, less bleeding, and a very interesting results in the donor, and similar results in the recipients. You can see here it's the mother, the first mother we operated, and her son, who is now an adult, and he is doing very well. This technique has disseminated, and I just took these two examples for pediatric explantation. The first series of our friend Kyun Kim in Seoul, and this paper from Gauthier and Monakov in Moscow, in Russia, more recent series. And to summarize the situation of laparoscopic left lateral sectionectomy for pediatric transplantation, I want to show you this paper we published a few years ago with at first sight, it could be a strange comparison, but we compared liver donors to kidney donors. And this is a multicentric series coming from both Eastern and Western centers. And you can see we gathered the data of 124 liver donors and compared to 300 kidney donors. And we showed even after matching on sex, age, BMI, ASA score, comorbidity, that in the liver donors group, there were less complications and a lesser CCI in the liver donor group compared to kidney donors. So that we concluded from this study that it was the first validation of left lateral sectionectomy in living donors. And we now are able to propose laparoscopic donor hepatectomy as a standard practice, at least for pediatric transplantation. Of course, for adults, the experience was much more limited at that time. You can see here the review a few years ago. It was only case reports. And then the first short series were published, like this one from Fernando Ortela, who published these 5 first cases. And interestingly, he found some advantage regarding the CCI, the Comprehensive Complication Index, in favor of laparoscopy compared to open. And another point that I think is not a detail, it's that there is a clear advantage regarding the scar-related discomfort or complications, which is probably an important point for living donors and the rest of their life. This is the first cases published by Kyun Kim in Seoul, showing probably the first to insist on the selection of donors, and especially regarding anatomy and graft size. I will get back on this later. In this paper from David Kwon, when he was still in Seoul, there is a very important point, because David showed that there was a marked increase in severe morbidity in case of anatomical variations of portal vein or bile ducts. And this is probably the most active group now. It's a group of KSU in Seoul National University Hospital. And you can see on this first important paper in MG transplant that he switched completely from open to pure laparoscopy, right hepatectomy in 2016. And he published several papers, very interesting, but I chose this one from last year. Fernando showed us already this paper. He reported more than 200 pure laparoscopic right hepatectomy. It's a high number, it's even much higher now. And he compared to open cases. And you can see here that, as we could expect, there was a shorter hospital stay in the laparoscopic group and less minor complications. But also, as expected, the operative time was a bit longer, but also the time to remove the liver graft and the warm ischemia time was longer in the laparoscopy group. And this probably explains this very important point that the rate of biliary complications in the recipients is higher, and both early and late complications are doubled in the group of laparoscopy. And I think that this is a warning, and it's very important that we must improve the technique, probably of bile duct mapping, and also of the way we cut and close the bile duct. A few comments for this talk. I want to, of course, to tell you that how to begin or to start a program of laparoscopic donor hepatectomy is a very important to define. And I think that the most important point is to combine both expertise in LDLT by open surgery and laparoscopic liver resections for tumors. And this cross-fertilization, if I can say, allows to start minimally invasive donor hepatectomy in the best conditions. And if you add some proctorship by another expert helping you for the first cases, is even better. For pediatric transplantation, the left part of the liver is easy to mobilize. There was very few bridging structures and almost no anatomical contraindication. So probably the best is to start with this kind of surgery for pediatric transplant. Very different for the right liver, of course, because anatomical variations are frequent and the right part of the liver is much bigger than the left part in most cases. So it's very important to select the best candidates, especially in the early phase of the program, and to select donors with a model anatomy and not too big right liver, if possible, of 700 grams or less. This is also the advice, for instance, from our friend Kyun Kim in Seoul. Again, I show you this paper from David Kwon showing that there is an increase in complication when you are donors with anatomical variations. I think it's very important to remind this, even though the group of KSU showed no overmobility in case of portal vein variations, even complex one. But again, I want to have a word of caution in case of anatomical variations. As you know, and I told you earlier that there was a gap of 11 years to move from the left retrosection to right liver, because it's much more complex, not only because of anatomical variations, but also to cut the liver. And it took time. And you know that the first cases were done with a hand-assisted technique. Then some teams moved to the hybrid technique, especially popular in Japan. And then to get to the pure laparoscopic technique. But of course, it's probably the best one compared to the others. Regarding the technique, little by little, we have now a quite well standardized technique, and the 4 steps are probably well accepted in all centers. First, to mobilize the right liver, dissect the right portal pedicle, parenchymal division, and I think that the point to be very studied and improved is this time, this step, cholangiography. And we saw with Fernando Telar that probably ICG fluorescence has a much greater place now, and it's more and more important. And the technique itself is improving. And the way we cut, we divide, and we close the right bile duct needs to be still studied. So to conclude with this talk, I would say that laparoscopic donor hepatectomy requires, of course, a whole set of gear and surgical skills. Overlapping experience in both open LDLT and laparoscopic liver surgery is mandatory. Laparoscopic left lateral sectionectomy for pediatric transplantation is now standard practice. I think we can say that. But laparoscopic right hepatectomy for adult transplant is a more complex procedure with a steep learning curve, and it requires an appropriate selection of donors, as I tried to show you in the previous slide. I thank you very much for your attention.
Very nice talk, Professor Subrin. We'll leave the question and answers till the end. Dr. Sudhindran is there.
Oh, hi.
Hi, Sudhi, you can invite Mark.
Okay. I think so far we've been dealing with laparoscopic donor hepatectomy. Again, the problem is here, as Dr. Subrin was mentioning, the cross-fertilization between experience in open donor hepatectomy and minimally invasive hepatectomy is so difficult to attain these days, which is where perhaps a robot may come in, because your learning curve is probably less steep. I think Vivek is laughing. So Dr. Mark's Stedevant is going to talk to us about the robotic donor hepatectomy. Please, stage is yours.
Okay, thank you very much. I'm just gonna pull up my screen here, if I've got it.
Hello, Mark.
Yes, we can see.
Okay, excellent. Very good, and big kudos to the entire Fortis team. This has really been a really educational morning for me, and thanks again, Ashish, for the invitation.
Sorry to interrupt, Dr. Mark. Can you switch the duplicate window? This is the external view, presenter view.
Say that one more time.
We are seeing your presentation in presenter view.
Oh, okay. Let me see here.
I think you can go to slideshow. You can go to slideshow. And
go to display setting. Top. Go to display setting. Second.
Oh, I'm sorry.
ISFL.
I'm not sure what it's doing wrong here.
I think it's okay. We can see this. You can continue like this.
Okay, I'm sorry, but I must be showing this. I'm not sure how to get rid of this, to be honest with you, but. Okay, I'll just do the best we can here, I guess. So again, thanks for the invitation. And so I'm going to be talking today, not as a robotic expert like Dr. Sudhedran, but more as someone who has really watched the evolution of a robotic donor program come from really infancy to one of the better programs, I think, in the world. As I spent time in Riyadh with both Dr. Broering as well as Roberto Troisi. And I'm now in the United States trying to emulate that program. But as has been discussed by a number of folks, including Oliver just a few minutes ago, I think the main theme of my slides or talk is really about the focus on collaboration with robotic donor hepatectomy. The story really in Riyadh started back in 2013 when Roberto Troisi from Ghent came to collaborate with Dieter in setting up a pure laparoscopic left lateral section program. So before that, really, there was no laparoscopic hepatic resections done in Riyadh. But with Roberto's help, it was set up, and within really 4 years, there was complete universal adoption of that technique with relatively good results, and over 120 were done in just over 6 years. So based with that framework, we really attempted to move on with full lobe laparoscopic donor hepatectomy, and again sought a collaborative approach. Our team sought guidance from Dr. Su, has been discussed multiple times on talks so far. And we started this in April of 18 and went for about 6 or 8 months and accumulated about just about over 25, 26 cases with reasonably good results. We were happy with the low complication rate, but we were still somewhat struggling with really getting to where we wanted to be, which is a pure laparoscopic approach. I would say the vast majority of the cases ended up being a hybrid approach, which was of course not our ultimate goal. So really there was already a bit of a plan B at that time, in that we had contacted and started to collaborate with Yaoming Wu and PD Chen, who by that time, as many of you know, in 2016, published the first, really large series, or 13 patients. It wasn't a large series, but it was the first really substantive report on right lobe robotic hepatectomy. So our team spent some time in Taipei for a couple of weeks, and then actually Dr. Wu joined us in Riyadh for about 2 weeks, where we did 5 or 6 cases to really kick off the robotic program. And really it came at a good time in that our live donor numbers at King Faisal were going up to where we were at a point where we were doing almost 100 a year. And of course, our pediatric program was always fairly busy. So it really gave our robotic program a lot of practice, if you will, doing a lot of donors at that time. Again, our hepatic resection volume was very low, so this was the main framework going forward to set up this program. So based on that, this is ultimately the technique that we developed there in Riyadh. Started with, this is about a 5.5-minute video, but obviously starts with the standard dissection or transection of the falciform, followed by mobilization by dividing the area over the cava here. We mark the groove between the right and middle hepatic veins for future reference. And then one of the things that we really, I think, did better with was mobilization of the right lobe as compared to our attempts with laparoscopy. We felt we had a much better view here, and using the fourth arm of the robot, felt we had pretty good ability to mobilize the right lobe as pictured here. As far as handling the small retrohepatic veins, again, as you can see here, we're doing it with the with some clips that we initially were a little bit nervous about using just clips on the cava, but over time became more and more comfortable with just burning the smaller veins. And then on this more medium-sized retrohepatic vein, as was discussed by Dr. Turkey, this is one of the pneumatic clips that came out about that time, the Challenger clip, which is really a very reliable clip, and we felt very comfortable using that, even just a single clip on the cava. And then for these larger retrohepatic veins, or this is actually probably the M.I.C.E vein, this is where we would use the, we would typically use the Ethicon stapler for that. As far as the tunneling, we do like to do the tunneling maneuver as we do with the open procedure. This, I think, did have a little bit of a learning curve, but overall, after 10 or 15 cases, we got reasonably fast at it. Typically put just a hemolock here to make sure it didn't slip back through. But again, our big focus was to try to emulate the open procedure as we typically do it. So that was an important thing that we did. Cholecystectomy, pretty much standard. Nothing real fancy about that. As far as the dissection with the robot is a fairly beautiful dissection with this kind of 10x magnification and the precision that the robot allows. After the artery, of course, next is the portal vein. And then with the articulation of that the robot allows, we're able to get around the portal vein relatively easy. And then the length of the artery, as you can see here, is we're able to take that back to the bile duct. Then as far as transection, it starts with transient clamping of the artery and vein, followed by the ICG. We give about 0.5 milligram per kilogram just before clamping or just after clamping, which helps us with the demarcation. And then we don't use the rubber bands, but we use a very similar thing where we bring the sutures out to the lateral walls, which allows us to have tension for this transection, which is done completely by the harmonic stapler. As Dr. Turkey mentioned earlier, it was very difficult without the coups at the beginning, but we got used to it. As far as the cutting of the hilar plate, again, is aided by the ICG, and quite frankly, probably more so even because of the 10x magnification, which really allows that to be helped. This is what Fernando was mentioned before. This is where we put the probe into the bile duct to make sure that we're far enough away from the left duct. As far as the completion of the transection, this is a large segment 8 vein. Again, getting around it with the harmonic, and then typically, again, we were fairly comfortable using the Challenger clips on these small to medium or small to even large segment 8 branches. And then at the very end, a little bit more meticulous once we get towards the cava. So we'd use the bipolar, and then that would complete the transection. Emulating again the open technique, we really like to use 6-0 PDS, and we would typically do this in a running fashion, both on the bile duct and the hilar plate. And then that would set us up for the kind of the final drive home here with the bag going in, and then clipping and cutting the artery as we typically do in an open fashion. That's the portal vein, and then we kind of evolved over time, and now we're typically using the robotic stapler here. We're obviously using the, I believe that's one of the Ethicon staplers that we typically used at the beginning. And the bag is, of course, already there. And just kind of shake the graft in, and then take it out, usually through about an 11 centimeter fan and steel incision. So the first report that, again, Fernando, I think, brought this paper up was was based on to look at our early donor outcomes, was propensity matching a paper looking at 35 of the first 35 robotic donors. Again, not surprisingly, the operative time was about an hour and a half longer than or actually even longer, 3 hours longer than the open technique. The warm ischemia time was around 8 minutes, which hasn't really changed all that much, even over past the learning curve. I think one thing that was somewhat surprising to me, because I did a lot of these recipients, it seemed like there was more bile ducts, but when we actually did this initial analysis, there was essentially the same number of bile ducts and portal veins, suggesting that really, I think we kept true to our technical paradigms that we had set up in our open approach. As far as complications go, statistically it was insignificant, but in general we felt that we had less complications with the robotic donors at just around 6%. As far as bile leaks, essentially there was a single bile leak that was a grade 2. And as far as pain goes, we really never used any patient-controlled opioids. So in general, we really felt that the donors could get by with having fairly minimal opioid exposure due to the fact that we were using the robotic technique. So overall, again, the complications in these 35 patients, again, this is the live donor recipient outcomes, not much different. The grade 3 and above complications was 34% in the robotic, in the patients receiving robotic lobes, compared to about 40% in the open group. The re-laparotomy, retransplant, and early death after transplant was essentially the same for both the robotic and open group. So in general, we felt like we were still producing a high quality graft for our recipients. As far as left lobe donation, again, we did a propensity. This is actually unpublished. I think we're probably going to publish it within the next year. But looking at 21 robotic left lobes, again, pretty much the same theme. Operative time, even though it's shorter than the right lobe, it's still a bit longer, about an hour compared to the open group. The warm ischemia time was essentially unchanged. When we looked at all of the liver function tests in the donors, by day 3, they were all essentially the same between the robot and the open techniques. Again, complications were essentially unchanged in between the open and robotic groups. And again, very few, essentially just one patient required a PCA due to diminished pain. As far as the outcomes in the left lobes, again, I think the main thing that we had looked at was grade 3 and above complications down here, which again was around 40 to 48%, which is essentially the same between the two groups. And the biliary complications, there was two biliary complications in each group, which was usually around 10 or 11% as our early leak rate at King Faisal. As far as the retransplant and perioperative death, again, maybe a trend less with the robotic produced grafts, but essentially statistically no difference. So even more recently, and kind of getting towards the end of the slides here, but more recently, I looked at what had happened really over an 18-month period since we started the program. By about 8 months ago, we had done 175 robotic donor hepatectomies. I think as of yesterday, I think we had done 250. From the adult to adult, about 70% of them are done with right lobes, 30% with left lobes. And to date, really continued to have good outcomes with no blood transfusions. The overall complication rate of major complications, at least grade 3 or above, is now a little bit under 7%, with about a 1.5% leak rate, and 2 cases, I believe 1 left lobe. I think actually both of them were left lobes had converted to open procedures. And I think most interestingly is that over that 18-month period, there was really pretty rapid adoption of the technique, much more so than at least our group could produce with the laparoscopic technique, in that we really took on all comers, and only really in that 18-month period, only 6 open cases were done. So we really kind of took it on and really did almost every donor in a robotic approach. So there is still a lot of questions, I think, to answer. Based on my observations, I think one relatively irrelevant question is whether robotic is better, worse, or the same as laparoscopy. I think just listening to the last 2 hours of talks, there's a number of people just in the group that we've enjoyed listening to today that obviously can do laparoscopic donor hepatectomy very, very well. And I think it's really to each their own at this point. Obviously, robotic, I think, is more expensive and may not be as disseminated broadly, but I think that's time to tell to a certain extent. The other question is, have we truly, we've got all these experts here today, but as a group, even in the United States, have we really entered the area of minimally invasive donor hepatectomy surgery? And I'll leave the answer to Dr. Sohan, who, after he visited us in Riyadh, was pretty strong, I think, in his kind of prediction, and that the days are numbered for open surgery. And so obviously, I think that kind of behooves all of us to think about what we plan on doing in the future. So myself, I've left Riyadh. I'm now at a really an up and coming program. And if I'm lucky, in 2 years, we'll do 2 to 3 live donor cases a month, as opposed to what, Vedanta would do in literally 1 day or 2 days. So myself, I'm going to have to continue this kind of collaborative, I think, approach. There's a robotic surgeon here by the name of Jim Park, who's done well over 250 cases now. And I think it's going to be, obviously another collaborative approach by myself to really work with the robotic team to be able to really take on this with the really limited number of donors that we'll do here. And I think all of us will have to figure this out, because definitely the donors will be asking for it in the very near future. So thank you very much for your attention.
Thank you very much, Olivia and Mark, for excellent presentations. Because this session was running late, so I could only intermittently kind of be with you. I'm sorry, because I had others, my patients were waiting actually to see me in clinic. So anyway, but it's a pleasure to hear, the masters deliver excellent talks. And many of your points, Mark, which you made are very relevant, and obviously, I think this is a curve which is on the up, and more adoption of this will happen in centers and among patients. And you're absolutely right. I get asked by every second donor whether they can have the minimally invasive approach, literally. And we only have like a 1 to 2 robot days a week, so we obviously can't accommodate everyone. So that's where we are. And I think the credit of making us start obviously goes to Dieter Boring. There's no doubt about that. And he's been our teacher, and the motivation, the cause of the motivating factor was the entrance program. I mean, they started first, and we were kind of inspired to go after the robotic donor hepatectomy. Why not laparoscopic? In the earlier days of transplantation, I used to do laparoscopic donor nephrectomy like 20 years, 15 years ago. And but I find that there are several advantages to the robotic approach, and I'd like to hear from Olivia and you quickly. One of which being that it is easier to pass it on to multiple members of your team, so the learning curve is not quite as steep. The expertise needed in laparoscopic donor hepatectomy, I might say, would be far greater than to accomplish a robotic donor hepatectomy. So from that point of view, in terms of adoption among a wider range of surgeons, perhaps the robotic donor hepatectomy has an edge. What do you think, Olivia? You're on mute.
Oh, okay. Can you hear me?
Yes.
Okay. I agree with you. I'm already convinced by the robot. I have only an experience in liver resections for tumors, not for living donors. Probably, I have no, of course, high evidence to say that, but I think that the learning curve is shorter with the robot, and it is a safe instrument. And the main problem to me is the access to the robot. The number of the robots, of course, it's a very expensive tool, so it's difficult to. We have some competition with urologists. With
yes, of course,
you know what I mean. The laparoscopic technique is not dead yet for
No,
living
it's not.
donors.
It's not.
But I am very impressed by the robot, and it's a wonderful technology. I totally agree with that.
And Mark, your 2 cents?
Yeah, no, I mean, I think laparoscopy is better based on exactly what you said is or what Oliver said is getting access to the robot is difficult. So if you can do it, great, do it. Because I do think it's a little bit more accessible, but I definitely, based on my experience there with both starting with laparoscopy and then robotic, our group for sure, we were just able to pick up on the robotic techniques faster and better, and we felt we could emulate our open technique better. But maybe we were just, maybe that was just our lack of skill. I don't know, but that's just how it ended up working there. And we were in a great situation, and that now Dieter's even got 2 robots. But you'd have to move to Saudi Arabia to get those kinds of perks, and none of us want to do that for very long. But so that's how it worked out there. And I don't know, in the US, I think we'll just have to see how this is going to go. But I think it's going to be a much bigger struggle just because of the lack of volume that we typically have in our programs.
Vivek, how many of you do laparoscopic donor hepatectomy? Just you or your other team members as well?
No. Now we have completed about 75, and Vishal is there with me, Dr. Vishal Chaurasia. Dr. Kaleem is there. Now I make it a point to train them, or actually we we all train together, So they do steps like cava dissection, transaction. So both of them, especially Vishal, is able to do, I would say, more than 60% of donor hepatectomy laparoscopically. I think it's the mindset of training. I agree that robotic platform is maybe slightly better, because of course degrees of freedom, suturing, and all those kind of things are much better. But as Olivier said, the percolation of robotics to different centers, limitation of time, cost, and everything is there. I think in my personal opinion, I've gone through for last, we really picked up in last year when COVID was there, because we had enough time, less number of patients. But I strongly believe that if we can divide laparoscopy training into small snippets and actually protocolize it, then it becomes much easier to train other people. Why we say learning curve is more? Because we struggle in mobilizing the right lobe. We don't know where to lift, from which instrument to use. Why not standardize the procedures and pass on, percolate it to the people who are going to do it as juniors, or people who could be mentored. So my opinion is that although we tried robotic also, but because at one point of time we can concentrate only one thing, so I thought of completing few laparoscopic and then jump to robotic. That's my personal opinion. But of course, I see there is a great divide between robotic and laparoscopic surgeons. The mindset goes in that direction. I think problem solving is like that only. If you enter into robotic, you solve problems differently. If you enter into laparoscopy, you solve problems differently. So that's my opinion.
Yeah, I think, hi Sudhi here. I think since the session is about the future, I mean, if you look at it, the robotic itself, particularly for living donor hepatectomy, is at its infancy, because none of the instruments are made for a hepatectomy. I mean, I know Mark said he uses a harmonic and he's quite comfortable with it, like a CUSA. But then, imagine if you have a robotic CUSA, it'll make things so much more easier. Likewise, robotic suction, a table which moves along with the robot. So there are so many things that's going to come in the future, in the near future. I mean, all this will come. And once that happens, the robot will become a lot more easier. Even the tactile numbness, I'm sure people will get over it, and you'll have the feedback. So all those things will come soon. And I think probably the future is going to be the robot, I think, the way it's going. Mark, I just wanted to ask you, I mean, do you always do a hanging maneuver, even if it's a large right lobe liver with a big Makuchi, etc.? Do you always manage to do a hanging maneuver in all the cases? Because sometimes we find we don't do that as a routine. the hanging menu?
Yeah, definitely the last. I've been gone there for now, for a number of months. But yeah, he's still doing, and I would say, I think, yeah, pretty much every right lobe, he's able to get the hang maneuver done. I think I've seen a video of yours, and you don't worry about that too much, but at least with the technique that Boring set up there, that he does it on every case.
That's very impressive.
So the Professor Swain, what I don't have any experience of robotic donor hepatectomy. So as experience from laparoscopic surgery, the cost is higher in donors. So what could be the cost looking at if we routinely do donor hepatectomy? Additional cost for laparoscopy, additional costs is somewhere around $3,000, and for
So we are able to do it for about 2,20,000 extra.
Okay.
So which is similar.
No, not huge difference, right?
No, similar. Isn't it?
Yeah.
We too same. I think 2 lakh. It's under 2 lakhs.
Right.
I mean, more than the open one, because the staplers will come and a few instruments.
So just for everyone, 2 lakhs is 200,000 rupees, which is approximately $3,000. $3,000.
Yeah. Any other questions? Do you have any questions? Written question answer session.
There are no open questions, I think.
Nothing on the chat.
Yeah.
I think, can I add something there, Vivek? Is Krish here?
Yes, sir.
Yeah, no, I think I've enjoyed the discussions, and I think, we had a recent similar webinar that was held when David Kwon spoke. And I think one of the things that's never been looked at is the laparoscopic 3D with all the advantages that you have in comparison with the robot. And as you'll always have both sides of the argument, as you rightly pointed out. But I think when you look at laparoscopic 3D with all the haptic feedback that you get, is completely different when you compare that to a robot. The newer robots are coming, as Sudhi said. So there are robots that are coming out with haptic feedback, and there are 2 of them already in the market. So I think things will improve as time goes, and then you'll have the full combination of the versatility of the instruments, which allows you the dexterity to cope with difficult angles for suturing, etc. And that in combination with the haptic feedback will be probably the future, I think.
There's someone who's coming across to demonstrate an equipment which you can actually convert from robotic to laparoscopic modes, without having to de-dock and everything.
So that's the Senhance robot that's coming out, which is got transcenteric.
So we've got an online demo scheduled in the near future. So I'm going to get back to you guys.
I think the future is exciting, and I think
yes, future is exciting. Yes.
Thank you very much.
Thank you, Krish. Thank you.
Thanks. Great to see you all. Thanks, Vivek.
Same here, sir.
Thank you so much.
Thank you.
Such a useful session. Thank you.
Thank you.
Come to the end of the day 1 session, and thank you all the faculty, speakers, the chairpersons, and the delegates. Tomorrow we will join at 4 p.m. Indian Standard Time, and the agenda for tomorrow is for transplant research and transplant oncology. Hope to see you everybody tomorrow. Thank you.
Thank you very much.
Thank you.
Thank you.